I think we can go ahead and get started. Good morning and welcome to the March 13th meeting of the Patient Protection Commission. We're going to go ahead and get started. Chair Sexton, I'll hand it over to you.
Thanks so much. Good morning, everybody, and welcome to the public meeting of the Patient Protection Commission. My name is Bethany Sexton. I'm the chair for this commission, and I'll now call the meeting to order. Mr. Malmlove, if you'll do the roll call.
Perfect. Thank you, Chair. Commissioners, please identify if you are present when you hear your name called. I'll start with our voting commissioners. Dr. Jonathan Chastain.
Present.
Dr. Mark Glyman.
Present.
Dr. Ikram Khan. We'll mark him present when he arrives. Ms. Marilyn.
What is his name, your doctor? What's his first?
Dr. Ikram Khan. Sorry. Ms. Marilyn Kirkpatrick.
Here.
Dr. Andrea Peterson.
Present.
Dr. Adam Porth.
Present.
Dr. Travis Walker.
Present.
And Ms. Bethany Sexton.
Present.
I'll now move to our non-voting ex officio members, Insurance Commissioner Ned Gaines.
Here.
Director Stacy Weeks.
Here.
Executive Director Janelle Davis.
Present.
Executive Officer Teresa Karsten. We'll mark her present when she arrives. Chair, that concludes roll call and we have a quorum.
Excellent. Let's move to public comment.
That moves us on to public comment. First, I want to share that we are soliciting policy recommendations, and you can fill out the form linked here to fill out all the information for possible consideration by the PPC. And we ask that recommendations be submitted on or before April 1st. So now we'll move on. This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 981-401-478#. Please press *5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Persons making comments will be asked to begin by stating their name for the record and spelling their last name. If you wish to provide public comment and joining by phone, please press *5 to raise your hand. If joining by the computer, use the raise hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
Thank you so much. We will move into the meat of the agenda, and we're going to move to item 5. We do have a very full agenda today, so I'm going to ask all of our presenters to try to keep to their time, and we'll keep an eye on that as well. But really excited for the lineup that we have today. To start, we're going to go through a presentation on national trends and best practices in perinatal health care. And I think we have some representatives from the Princeton State Health and Values Strategies team today to share that.
Yes, that's us. Thanks. Do you want us to share screen so we can run through the slides?
Please do.
Okay. I'm not used to, you have to bear with me for a moment because I don't usually work in Teams. Hopefully everyone can see this. I'm going to start it from the beginning. Okay. Okay, that should be a better view for everyone.
Perfect. We can see it. Thank you.
Great. Thank you. Okay, well, thank you so much for inviting us to present today. My name is Sally Maven, and I'm the Director of Programs at State Health and Value Strategies. And I'm also joined by my colleagues, Becky Lopez, who is a Program Coordinator, and Jamila McLean, who is our Director of Health Equity. So our agenda for today's presentation is to provide the Commission with an overview of national trends in perinatal health care and highlight what other states are doing to support perinatal health. We're going to focus on 5 areas of interest. So those are payment reform. I'll start by covering that. And then I'm going to hand it over to my colleague Becky, who's going to review strategies to support the workforce. And we're specifically looking at midwives, doulas, and other providers. Then Jamila will take over, and she's going to talk about what other states are doing in terms of how they're looking to leverage the Rural Health Transformation Program for the purposes of improving the quality and access to perinatal health care. And then I'll shift over to talking a little bit about behavioral health and trends in other states. And we'll end with other strategies to increase access to care. And obviously leave time for questions. So let's see, before we get started, I just wanted to share a little bit about state health and value strategies, because I know a couple of you on the line are familiar with our program, but not necessarily the commission members. So we are a program that is housed at Princeton University, and we are solely funded by the Robert Wood Johnson Foundation. Our director is Heather Howard, and she is on the faculty at Princeton, which is why we're housed at Princeton University. So our program provides technical assistance to support states in their efforts to transform health and healthcare. And we do that through a variety of different means. We, on the lower scale of interaction, produce webinars and put out publications on pressing policy topics. And then on the higher scale of interaction, we'll actually work one-on-one with a state. And somewhere in between is the kind of work that we're doing today. And we're happy to take more questions about our model at the end for those of you who are interested. So one core component of our model is sharing lessons learned from other states. And that is a really important piece, as states we find are often very willing to copy one another, which is great, so that when there are success stories, we can highlight and lift up those successes and help states implement those successes elsewhere to spread transformation. So as I said before, today's presentation will review strategies implemented in other states to improve and increase access to perinatal care. The methodology that we employed was we conducted a scan of academic articles produced by other sort of peer organizations to state health and value strategies, to identify strategies being implemented in other states related specifically to the interests for Nevada. And where available, we've made note of the evidence base for the strategies as they've been implemented in other states. I also just want to highlight, and I know you all are aware of this, that there are significant other additional considerations when thinking about perinatal care and the quality of that care and its impact on the people that are receiving it, which is the role of social drivers of health, food insecurity, access to housing, the many different other factors that play a role in the health and well-being of those who are pregnant and postpartum. And just to encourage the commission, while I realize it's outside of the purview, to think about the opportunities to work across silos. Okay, so I'm going to start off on payment reform with a quick overview of sort of the most well-known payment models. I'm not going to go into a lot of detail here, and also just to say that we will, of course, make the slide deck available afterwards as a resource. The text in red and underlined is links to the outside resources and examples. So we want to make sure to make that available to everyone after the fact. So these are the most common payment models being implemented by states. The first is the maternity payment bundle, and we'll also go into the question that arises around unbundling the maternity payment. But essentially, the payment bundle is a comprehensive payment for all services provided during an episode of pregnancy-related care. The other model to highlight is the episodes of care, with different than the maternity payment bundle, in that it creates incentives to manage costs and quality across a set of services. And one of the examples highlighted here is Tennessee, which is well known for its episodes of care model with regards to maternity. Blended payments. This is a payment model that combines payment for both cesarean and vaginal birth, really as a means of disincentivizing cesarean births when inappropriate. And then pay for performance. Pay for performance is not unique to maternity care, or I should say to perinatal care. It's used obviously across Medicaid managed care. But this is essentially when a provider is incentivized to meet certain quality goals through payment. And that can take a variety of different forms. We've highlighted a couple specific to perinatal care in California here. And then reduced or non-payment policies. This is a strategy where states essentially reduce the payment they would make for a cesarean birth or do not cover certain procedures. So I'm just going to run through those quickly because I want to dive into some other more specific models of interest that were flagged for us that you all would be interested in, which is the pregnancy medical home. So this is both a payment and care model. So the primary state example here is North Carolina, where providers have been paid enhanced rates for coordinated comprehensive pregnancy care. So including risk screening, care management, and postpartum visits. It's been in place, I believe, since 2011, so it has a significant track record. Although, as I understand, it does not have a kind of super robust evaluation of impact. But the outcomes that have been found as a result, to be associated with the program is an increase in tobacco cessation counseling and also postpartum visit rates increased among participants. The other model that we wanted to highlight was the use of accountable care organizations. The two sort of standout states in this work are Oregon and Massachusetts. I've just included Oregon on this slide, but essentially an accountable care organization, which I'm sure many of you are familiar with, is a provider-led organization. And there's a shared savings and risk arrangement within the payment model. And in Oregon, the setup there is what they call regional coordinated care organizations, and they provide comprehensive, well-integrated services. And with regards to perinatal health specifically, there's the priority of perinatal health is part of the savings and risk arrangement. So the important feature of what makes sort of Oregon's model particularly successful is that OB/GYNs and midwives are included in the accountability structure. And they've also have layered in robust quality metrics tied to payment. So, accountable care organizations obviously exist across the United States in a variety of different guises, but the model in Oregon really centers the roles of OB/GYN and midwives. So just to make that distinction. And the ACOs in Oregon and Massachusetts focused on, with the emphasis on perinatal care, have been found in randomly controlled studies to reduce the likelihood of low birth weight, as well as abnormal conditions in infants, and also increase the use of prenatal care, but with the caveat for certain racial ethnic groups, so not across the board. Okay, so we were asked to talk a little bit about the unbundling of maternity codes. So to those of you who may or may not be already aware, so in September of last year, the American Medical Association CP editorial panel voted to shift to back to fee for service from a bundled payment. And this will be effective as of January 1st, 2027. So the 16 global obstetric codes will no longer be billable. So the change was essentially driven by ACOG and ACNM. And originally, maternity care was bundled to decrease C-section rates. So since you're only paying one payment, one rate for the entire maternity bundle. The idea would be to incentivize, right, away from more intervention to away from C-sections to vaginal births, given that, under the fee-for-service model, folks were charging for a higher rate given the complexity of the procedure. And ACOG and ACNM really advocated for the change as they maintained, and it's been proven to in research that I can touch on in the example of Arkansas, that it really has not functioned as a value-based payment, as many of the bundle payments, or the majority of bundle payments, are not tied to quality measures. And ACOG and ACNM's argument was also that it doesn't reflect modern prenatal care, which includes increasingly more screenings and counseling that was not accounted for in the bundle payment. So 2 of the examples of other states I wanted to highlight here. One is Arkansas, which was in fact the early adopter of a bundle payment for perinatal care, and one that's been the most studied. And they ended their model in 2021 after finding that while it reduced costs, it did not have any impact on quality. And then I just wanted to highlight that Iowa has actually already gone ahead and unbundled their global maternity payment as of October 1st, 2025. There's sort of limited information about the work that Iowa is doing. I've linked to it here, but to highlight that this might be an example as they roll it out more to look to. There's just not very much at the moment yet on available publicly. Okay, now I'm going to hand it over to my colleague, Becky.
Thank you, Sally. So I'll start by quickly introducing myself. I'm Becky Lopez, Program Coordinator with State Health and Value Strategies, and today I'll be covering the workforce section of our presentation. This is one of the most critical levers states have to improve access to perinatal care, particularly in underserved and rural areas. And as Sally mentioned, we'll start with midwives, then move to doulas, and finish with some broader workforce strategies around other types of providers, including community health workers, physician assistants, and peer specialists. I'd also like to reiterate that we aimed to provide a broad overview of several state examples throughout, and our presentation is fairly high level. However, the deck is populated with hyperlinks should you wish to explore a specific state example in more detail. Next slide, please. So the evidence base for midwifery care is strong. Research consistently links nurse midwifery to better outcomes across a range of measures, including lower rates of cesarean birth, labor induction, perineal tears, and use of regional anesthesia, as well as higher rates of breastfeeding initiation. These outcomes matter not just clinically, but economically, as lower intervention rates typically translate to lower costs per episode of care. And it's also important to acknowledge the equity dimension. Indigenous and Black midwives carry generational knowledge of holistic community-centered care, but beginning in the late 1800s, state regulations increasingly stripped midwives of color of their ability to practice. So expanding midwifery care now is both a workforce strategy and a health equity strategy. Next slide. So as I'm sure you're all aware, before midwives can be reimbursed by Medicaid, states must address licensing and scope of practice. And I'll just provide a quick overview of the 3 main types of midwives at the national level. Certified nurse midwives are licensed in all 50 states, are required to have a RN license and a master's degree, as well as certification by the American Midwifery Certification Board. Then certified midwives are currently licensed in 9 states and DC. These do not require a nursing background, but they have completed graduate school in midwifery and passed the same certification as CNMs. Then certified professional midwives, which are licensed in 37 states and DC, are typically trained via apprenticeship or specialized accredited schools, and they have a different certification than CNMs or CMs through the North American Registry of Midwives, and are typically trained for out-of-hospital births. And studies show that integrating all 3 types of midwives produces significantly better outcomes than relying on CNMs alone. So Nevada currently licenses CNMs and allows them to practice independently of physicians. That's a meaningful policy advantage compared to other states that require collaborative agreements mandating physician supervision. However, Nevada does not yet license CPMs or CMs, which can limit access, particularly for communities that would benefit from community-based or home birth settings. And another key question worth exploring is, even where CNMs are licensed, do hospital credentialing policies or managed care organization requirements create de facto barriers to practice, especially in rural areas? So Minnesota and Washington offer instructive examples of states that have operationalized Medicaid reimbursement for non-nurse midwives. They differ in their licensing requirements, registry structures, and covered services. But if Nevada is interested, they could look to those models if considering whether to expand the licensure framework. Next slide, please. So Nevada is actually ahead of many states on reimbursement parity because state law and the state plan amendment require that CNMs be reimbursed at 100% of the physician rate. Approximately half of all states have reached that benchmark. But parity alone does not capture the full picture. 19 states, not including Nevada, now reimburse both CNMs and non-nurse midwives through Medicaid. If Nevada were to consider expanding licensure to CPMs and CMs, the reimbursement framework would need to follow. Additionally, 36 states, including Nevada, reimburse CNMs for services beyond maternity care. Nevada reimburses for smoking cessation and home visiting. Other states, including Indiana and Michigan, reimburse for substance use disorder and behavioral health screening and treatment. Missouri reimburses for family planning, well woman gynecological care, and some infant care. So expanding the scope of reimbursable services could significantly increase the value that midwives provide, particularly in areas where other providers are scarce. Next slide. So even with the right licensing and reimbursement policies in place, of course, the workforce doesn't grow on its own. So several states have invested directly in training, recruitment, and retention. California provides state-funded grants to expand CNM training in underserved areas, including support for accreditation. In Colorado, a federal grant funds a rural midwifery track with scholarships, stipends, mentorship, and rural clinical placements. Minnesota's state-funded loan forgiveness program targets CNMs and other advanced practice providers working in designated rural areas. And New Mexico's Medicaid Birthing Options Program addressed a major structural barrier, which is malpractice coverage for non-nurse midwives, and enabled them to bill Medicaid for home births. Next slide, please. So now we'll turn to doulas, a workforce category where Nevada has shown leadership nationally. Next slide. So doulas are non-clinical providers that provide support to birthing people. The research on doulas is consistent. Their presence improves maternal health outcomes and reduces maternal mortality. 27 states and DC now provide doula coverage through Medicaid. And Nevada has been a leader in this space, though it was one of the more recent states to add doulas as approved Medicaid providers, having done so in April 2022. The state quickly more than tripled reimbursement rates in 2023. So the current rate structure includes a base delivery rate of $900 in urban counties, a rate of $100 per visit for prenatal and postpartum visits with up to 6 visits total, and also a rural incentive that's 10% above urban rates with a maximum of $1,650, and an additional incentive of reimbursement for 2 extra visits for connecting clients to prenatal healthcare and dental services. Next slide. So one area where other states are innovating is postpartum reimbursement. Postpartum care is often where support is the most fragile, so these examples are worth examining. California reimburses up to 2 extended 3-hour postpartum visits, plus up to 9 additional visits at about $486 per visit. Rhode Island provides $1,500 per pregnancy, but they also allow unused prenatal visits to be reallocated to postpartum, so a flexible patient-centered approach. New Jersey and DC both offer $100 incentives for postpartum doula visits paired with a connection to an OB clinician. And Virginia provides $50 for a postpartum OB referral and another $50 for a pediatric referral. So these incentive structures are designed to close the gap between delivery and ongoing postpartum care, a period that has historically been a weak point in the care continuum. Next slide, please. And beyond reimbursement, states are taking systemic steps to integrate doulas into the care system. So in New Jersey, hospital doula rights legislation ensures that every birthing individual has the right to a doula and requires hospitals to maintain formal accompaniment policies. In New Mexico, the Doula Credentialing and Access Act created a voluntary credentialing pathway for Medicaid enrollment, along with the Doula Advisory Council and a dedicated doula fund. In New York City, the citywide doula initiative provides free doula support to underserved neighborhoods, and a recent audit found reduced cesarean and preterm birth rates for Black and Hispanic participants in that program. And then several states provide statewide registries of doulas, but some states like Michigan add additional filters that can help families search by county and also by doula's Medicaid enrollment status. And then typically to receive doula services through Medicaid, enrollees would need a physician recommendation. So California and New York have issued standing orders actually eliminating that requirement and eliminating a barrier to care. And then a quick note on private insurance coverage. Only 2 states, Rhode Island and Louisiana, currently require private plans to cover doula services. It looks like Nevada introduced legislation last year to do so, but it appears to have stalled. Next slide, please. So funding for training and retention of doulas varies significantly by state, but several models illustrate the range of approaches. New Jersey awarded a $450,000 grant to Health Connect One to support doula training, including support for processing Medicaid reimbursement claims, which can be a practical barrier that often limits doula participation. New York awarded $250,000 in expansion grants to CBOs for recruitment, training, certification, and mentoring. And finally, Washington State appropriated $200,000 to design and plan a centralized doula hub for training on enrollment and reimbursement. Next slide, please. So beyond midwives and doulas, states have pursued a range of strategies to expand perinatal workforce capacity. We'll look at 3 areas: workforce development and training programs, expanding the scope and mobility of physician assistants, and telehealth as a workforce extender. Next slide. So several states have taken integrated approaches to workforce development that go beyond a single provider type. New Jersey's Maternal and Infant Health Innovation Center provides culturally centered, equity-driven training for clinicians, doulas, and perinatal providers together, building a shared understanding across the care team. Oregon's How To program supports community health workers, medical assistants, and peer specialists through apprenticeships, stipends, and mentoring. Oregon also has provider incentives, including loan repayment, insurance subsidies, and scholarships for providers in underserved areas. Other states have expanded physician assistants' scope of practice to broaden care delivery capacity, and we'll look at that in more detail on the next slide. And then telehealth has also emerged as a critical workforce extender, and we'll address that later on slide 23. Next slide, please. So physician assistants typically practice with some level of physician involvement, and recent state reforms have focused on reducing the formal supervision requirements while maintaining physician availability for consultation. Physician assistant scope of practice is an area of active reform across states. Indiana recently enacted legislation to move from a supervision model to a collaborative model. This reduced the administrative requirements around prescriptive authority, eliminated some restrictions on prescribing controlled substances, and under this model, the physician must be physically present or electronically available for consultation and able to see the patient within a medically appropriate timeframe. Oregon also enacted legislation to replace supervision with a collaborative practice model. They eliminated physician to PA ratios and the requirement for physician names on PA prescriptions. Practice details and scope are determined through practice level collaboration agreements, which are kept at the practice site and not required to be filed with the medical board, but they must be available upon request of the medical board. So while neither of these states granted PAs full autonomous practice, both meaningfully reduced administrative friction and expanded practical flexibility, which can be particularly relevant in rural settings where physician availability is limited. I would note that while there's some research indicating that expanding PA scope of practice can increase the PA workforce supply, I didn't come across any state assessments specifically focused on whether these expansions improved perinatal health outcomes. Next slide, please. So workforce mobility is another dimension of PA practice reform. In South Dakota, House Bill 1146 was enacted just this year, which entered the state into the PA licensure compact as part of its application for Rural Health Transformation Program funds. The compact allows eligible PAs to obtain a privilege to practice in other participating states in the compact without maintaining multiple separate licenses. This is designed to reduce administrative burden, accelerate workforce movement across state lines, and improve access to care in underserved areas. And South Dakota's decision to do this was explicitly driven by the RHTP's recognition of the compact as a rural workforce strengthening strategy. Next slide, please. So lastly, while telehealth is not a substitute for in-person care, it has emerged as a powerful tool for extending the reach of the perinatal workforce, particularly in rural and frontier areas. I would point to a couple of different resources on this. KFF did an analysis of telemedicine and pregnancy care. CMS has a state Medicaid and CHIP telehealth toolkit, and the Commonwealth Fund has a resource on state policies to improve perinatal health outcomes, which all document state examples and best practices. So these are worth reviewing if Nevada is looking to refine its telehealth strategy, but a few areas where telehealth has demonstrated particular value in perinatal care include remote monitoring for high-risk pregnancies, perinatal psychiatry access and behavioral health integration, and e-consult platforms that allow rural providers to connect with specialists. And I know my colleague Jamila will discuss telehealth and additional workforce expansion efforts specifically in the context of the Rural Health Transformation Program in the next section. So I will turn things over to her now.
Thanks, Becky. And hello, everyone. I'm Jamila McLean. As Sally mentioned, I'm the Director of Health Equity, and I'm going to share a little bit about the Rural Health Transformation Program and provide a little bit of context in terms of how other states are approaching it. Next slide, please. So as you all know, the Rural Health Transformation Program, which was awarded under the HR 1, provided states with significant funding, the largest sort of infusion of funding dedicated solely to rural health. And for Nevada specifically, we saw that they were awarded almost $180 million in this first year. While the Rural Health Transformation Program does cover sort of like a large swath or a large bucket of priorities, we're going to focus on primarily on how states are approaching maternal health from the treatment, training, rule, and recruitment and retention aspect, as well as specific programs and activities. So when we looked at the Nevada's Rural Health Transformation Program application, we saw that their strategy to address workforce recruitment and retention really focused on a couple of areas. So thinking about how to expand and or create rural medical residency programs, introducing new or expanding financial incentives to help retain and recruit folks. So housing support, relocation and signing bonuses, as well as continuing medical education stipends. And finally, building that rural health workforce from scratch. So thinking about how to create pipelines from high school straight to sort of training and career pathways programs for rural residents. And when looking at that across sort of the national landscape in terms of how other states are approaching workforce recruitment and retention, there are a number of similar approaches, but we pulled out a couple here to highlight as well. So for example, New Mexico articulated that they are looking to expand Project ECHO, which is a program that allows for telementorship. So really allowing clinicians and other providers to upskill by being able to be mentored virtually. So really diving into that use of technology to meet folks across different distances. As Becky mentioned previously, there's a lot that can be done in terms of allowing providers to practice at the top of their license. And we did see in a number of applications, including Florida, Maine, and Vermont, options to expand the scope of practice for EMS providers and paramedics, which would allow folks to provide treatment to individuals in the communities where they are, understanding that it can be very difficult for folks in rural communities to access care given the long transportation distances that occur trying to get to hospitals. We also saw Illinois include a workforce expansion specifically around education and training for doulas and lactation consultants, and similarly for Pennsylvania, increasing the training and credentialing that's available for midwives, also sort of driving and increasing that workforce for the for perinatal care. Next slide, please. When we look specifically at opportunities for the perinatal population, I want to flag here that this is something that was consistent in almost all applications in the Rural Health Transformation Program. Addressing maternal and child health, morbidity, and mortality was a sort of key goal of most of the applications that we saw, including in Nevada. And with that, there was the inclusion of the Rural Health Outcome Accelerator Program, which really focused on how to develop and build on partnerships to provide behavioral and maternal health services in rural communities. We wanted to highlight a couple of very specific activities that other states included, as we know that there's a lot of opportunities to think strategically about what that collaboration can look like and how to invest in rural maternal services. So for example, and this one, some of you may have already heard of because it's gotten a lot of national attention. Alabama in their application has proposed utilizing telerobotic ultrasound devices and including labor and delivery carts in rural hospitals. As we know, many sort of maternity care wards are closing. Being able to have labor and delivery carts present across different delivery providers allows for access to be increased, and utilizing telehealth through the telerobotic ultrasounds allows for providers that may not be located nearby to provide care. In California, we also saw, and this has also been in many states, desire to really increase remote self-monitoring. So again, really leveraging data, technology, AI to monitor patients across distance, to allow for consultations, virtual consultations, and to provide access to perinatal psychiatric services. For many other states, including like Kentucky, we saw there was a huge focus on developing these comprehensive teams utilizing remote monitoring and telehealth. So thinking about how to provide comprehensive care teams that include doulas, midwives, clinicians, how they can utilize technology again through telehealth to really provide that comprehensive care. Another core or common theme that came up in highlighting Connecticut here was expanding universal nurse home visiting programs. There has been a lot that states have shown that to be home visiting programs to be quite successful, especially in that beginning years of life. And we did see several states include that in their rural health transformation applications. Another common theme that came up and highlighting here in Nebraska was the use of mobile clinical units. I will say broadly, there was a very common desire to meet people where they are. So mobile clinics, oral health teams, those were common examples that bubbled up in a lot of the applications. And lastly, again, really you see the commonalities coming through in terms of the remote monitoring. Alaska in their application included remote fetal monitoring, again, providing that opportunity to leverage telehealth and technology to treat individuals or to identify and provide early intervention for folks particularly with high-risk pregnancies. And I will stop here and turn it back to Becky.
Actually, you're turning it back to me. So I'm going to go over some behavioral health examples in other states. And I know that the last convening of the commission spent quite a bit of time digging into this, but just as a reminder, obstetrical complications are no longer the leading cause of maternal death 42 days postpartum. So instead, we've seen that research is showing that homicide, suicide, and drug overdose account for more than 1/4 of maternal deaths from 2018 through 2023. And also just to highlight that maternal mental health disorders are the most common complications of pregnancy and impact on average up to 1 in 5 of expectant and postpartum people. So just a significant, it seems, shift in some of our understanding of what's driving or the sort of postpartum period and the role of mental health and behavioral health. So highlighting here on this slide, 3 models and examples of states that have integrated behavioral health into perinatal care. With the exception of Pennsylvania, this isn't a perinatal care specific example. So Colorado, we wanted to showcase is an example of the co-location of care for women and their children. So it's a statewide program that's established to integrate obstetric healthcare services with behavioral health and substance use disorder treatment, which includes medication-assisted treatment services. And so by coordinating and providing such services at the same location, you're better able to meet the needs of both the parent and the baby. Rhode Island, we're showcasing as an example of a perinatal substance use task force. So this is a multidisciplinary group that's focused on care coordination with the goal of protecting the parent-child relationship. And then lastly, Pennsylvania has created centers of excellence, and these are primary care hospitals, federally qualified health centers, and SUD providers who deliver whole person care with community-based care management teams. And as I said, this isn't perinatal specific, but it provides an example of community-based care management to assist with care coordination and recovery support. I just want to highlight a few additional considerations in thinking about the behavioral health needs of folks during the perinatal period, which is monitoring for network adequacy. So it's an important component to ensure that there is in fact the network of providers to be able to meet the needs once referrals are made, when screenings are completed. Another opportunity is creating care management programs that include transportation and childcare support, since these are often barriers to individuals accessing behavioral health services. And looking to deploy peer support specialists into clinical and community-based settings to really expand the behavioral health workforce. Okay. Moving my own slides is clearly okay. So we were also asked to look a little bit into screening for perinatal depression. And so Nevada is already, it's a sort of a standout and across the landscape in the United States as one of the 11 states that require caregiver maternal depression screening at well child visits. A parent is screened 4 times between their child's birth from to age 1 period. And Nevada also requires managed care organizations to report on prenatal and postpartum depression screening HEDIS measures. So I talked before about the unbundling of maternity care, and depending on obviously where Nevada lands on how it will implement that, one of the considerations to take into account is sort of additional direction on screening and billing during pregnancy. So since pregnancy is such a key period for identifying perinatal depression, a potential opportunity is for the state to really consider how it can increase screening through direction around billing for around codes for during pregnancy. And then I wanted to lift up a few state examples. Massachusetts actually requires referral to a mental health clinician following a positive screen. And Alaska and Arizona also require referrals to a mental health clinician, specifically within Medicaid. Now I think I'm handing it.
I also want to just note we only have a couple more minutes for this
Okay,
topic.
yeah,
so I want to
sorry.
make sure we get through.
I know we're
any
trying to
key
get
points.
through.
No,
Okay.
Thank you.
All right, so Jamila, I'm going to hand it to you.
Awesome. Next slide, please. And I can go through these relatively quickly because we just wanted to wrap up with, as Sally mentioned, just highlighting some of the other considerations in terms of like the social drivers of health and how that can impact outcomes. So really just flagging, as you all I'm sure already know, that there are significant racial disparities in birthing outcomes, where we see Black, Indigenous, and Latina women have higher rates of morbidity and mortality. And there are a couple of state examples we've included here, including California and Minnesota, where they have implemented strategies to really reduce the bias that women, people of color experience in receiving care and how that can impact their birthing outcomes. Also wanted to flag that utilizing or engaging in perinatal quality collaboratives allows opportunities to learn from other states and achieve support as other states are also experiencing challenges as it relates to addressing perinatal outcomes. And if you go to the last slide, I think we have just we talked a little bit about this in the rural health section, where there are a number of states that are looking to pursue or expand universal home visiting. So we wanted to lift up New Jersey, Oregon, and South Carolina, who have seen great success in their home visiting programs. And finally, highlight additional considerations in terms of making sure that individuals are connected throughout the safety net. So there are a number of folks who are enrolled in Medicaid and SNAP and may not be accessing WIC. And WIC provides a lot of support so that women can have healthier pregnancies and improve birth outcomes by providing nutrition, education, breastfeeding support, and referrals to other social services. So we wanted to just flag that there is a federal funding opportunity available for states that would like to receive support to increase data matching between Medicaid, SNAP, and WIC. And I think that is our last slide.
Yeah, this is Dr. Khan. Sorry to interrupt. I had trouble joining in, but I've been connected finally, help of Dylan. So I've been on for a little bit.
Thank you, Dr. Khan. We'll mark you as present.
Thank you.
Awesome. Thank you so much for the great information, and would like to open it up if there are any questions from any of the commissioners. Dr. Peterson. Oh, it looks like you might be on mute.
I am, thank you. I am, thank you. I just want to make a quick comment. I appreciate the discussion around the midwives and doulas, but wanted to point out that they're seeing very low risk patients. So just making sure that we're keeping in mind that we have a very, a large number of high risk patients that would not be able to likely engage in those services or would need a clinician. So just encouraging everybody to keep that in mind as we have this discussion.
Yes, I think that's definitely an important note. Thank you for adding that.
Any other questions? Okay, thank you so much for all the great information. And we will continue to move on through the agenda. Appreciate you guys taking the time and to be here with us today.
Thanks for having us.
Our next presentation will be Health Workforce and Rural Access Initiatives, statewide healthcare access and recruitment programs, graduate medical education, and rural health transformation programs. And I believe we hopefully have Melinda Southard, Deputy Director, and Jason Bleak, Agency Manager, and Dina Schmidt, Program Chief, with us today to present.
Hi, Chair. Thank you.
Yeah.
Thanks. Just want to make sure you knew I was here. So yes, here with you guys. Thank you so much.
Awesome. We have about 40 minutes allotted for this. And I also just wanted to note that this item is listed for possible action, but primarily we're just going to have you guys share that information, and it's for informational purposes. But following it, we certainly will open it up for questions and any discussion with commissioners. So thank you.
Sounds good. Thank you so much. All right, I'm going to share my screen here. All right. And so today's presentation, we wanted to talk about some of the workforce programs with the Nevada Health Authority. And we do have some discussion questions kind of embedded in these slides too for the commissioners. So look forward to that discussion. So yeah, we'll talk about the statewide healthcare access and recruitment program, otherwise known as SHARP, the state's graduate medical education program, the rural health transformation program, and then some additional questions and discussion. So first talking about the SHARP program. This is a new workforce grant initiative that came out of the 2025 special session of the Nevada legislature through Senate Bill 5. This bill appropriated $60 million in one-time funding to be able to support this type of a grant program. Important note, the $60 million appropriation is not available until after July 1st of this year. So we're just trying to get everything as ready as possible to get things moving as quickly as possible after that date. This program is intended to support workforce capacity, of course, and sustainable healthcare in Nevada statewide. This bill also did require an assessment and a report every 2 years. And so the Nevada Health Authority is currently working on developing that assessment and report. And we just had a public workshop on this actually this week, earlier on Wednesday. So that information is available on our website. We do have the presentation and the meeting recording is available on the website. And I'll drop a link in the chat so you all have access to that. And let's see, what else do I want to talk about here? So there are a lot of requirements for the grant program. The Nevada Health Authority is charged with leading this grant program. So we have to develop the application process, the evaluation and scoring rubric, and then of course the subawards that would go out to the subawardees. So we're working on that process right now. We intend to have the request for applications in its draft form in May, along with a draft copy of the first report that's due. So we will be sharing those materials publicly during another public workshop that we'll have in May. And we intend to have the RFA fully published by the middle of July. So that funding opportunity announcement will be out middle of July. All right, and then I wanted to move on to graduate medical education in the state. So we do have a Graduate Medical Education Advisory Council. This council is comprised of 13 members, I believe, at the moment. And the responsibilities of this council is to, specifically to evaluate applications for the competitive grants associated with the state's GME grant program, and then make recommendations to the Nevada Health Authority on which applications should be funded. I did list some of the NRS and bill references here that relates to the Advisory Council's responsibilities. And so right now, the council has actually approved the request for applications for the GME program, the grant program. That RFA is live on our website. And again, I will drop that link in the chat for you all. So the application process is open, I believe, through April 28th, I believe. I'm so sorry, guys. I should have that date in my head, but I don't. But anyway, the application is out there. It's open. Encourage folks to take a look at that. An additional responsibility of the Advisory Council is, of course, to, study the graduate medical education program in the state and make recommendations for, different retention ideas for graduate medical education, other types of GME programs that we could develop in the state. And then, of course, recommendations about recruitment and retention of physicians so that we are able to meet the healthcare needs of the state. And then lastly, the Advisory Council is also responsible to work with the Nevada Health Authority and explore different ways that we can leverage federal financial participation in Medicaid to support further GME type programs. So the grant program itself, Senate Bill 262 that was just passed in 2025 gave some additional guidance and requirements around the grant program. So ensuring that the advisory council gives priority to these types of things. We want to see applications that are interested in leveraging federal funds from the federal government to maximize the impact of those grants. Of course, incorporate innovative delivery models, including different types of ideas such as rotations in rural areas and training in underserved areas of our state. Provide logistical support, which is super important, especially when traveling to rural areas of our state regarding transportation. And then, of course, housing and, just looking at all the different aspects of the GME program and how the state can better support that program to really ensure it is a robust program that is sustainable into the future. The GME grant program does have funding that can be carried over now from year to year. Previously, that was not the case. The Graduate Medical Education Advisory Council had to allocate all of the funds, and there was a specific deadline to be spending those funds. And now we have more flexibility to allow those funds to kind of roll forward from year to year, which is really nice. And let's see, what else do I want to say about this one? I think that, the basic gist of the GME grant program is to support programs that are either creating, expanding, or retaining programs for residency training and postdoctoral fellowships, of course, that are approved by the Accreditation Council for Graduate Medical Education. And then here, just wanted to provide you all a timeline for the GME grant round 8 now that we're in. So basically, back in January, the GME Council finalized the request for application and scoring rubric. We did open that application period. There it is. By February 13th, the application will close. So there's that date. We have it open for 70 days. Once the application timeframe is closed, it will go through a week-long administrative review with the Nevada Health Authority to ensure that all the components of the application are included there. And then the advisory council will be reviewing and scoring all of those applications. The advisory council will be meeting in May to both to provide, the scoring or the application review and recommendations to the Nevada Health Authority. So those meeting dates will be also posted on the website. And then we intend to execute all the subawards for this GME grant round 8 by June 30th of this year, and then starting those programs in July. All right, so first discussion question. Does the commission have any ideas for how we as a state can strategize about leveraging our state funds to best support the perinatal workforce, perhaps through the GME funding or other state funding? So just wanted to pause and see if there were any comments. Yeah, Dr. Chastain.
Hi, thank you, Melinda. I did have a question related to GME. In Indiana, we had a program where addiction medicine fellowships were subsidized for increased stipends for fellows in ACGME accredited programs, and also increased the size of those. Is something like that applicable under the GME initiatives here, or is that something that's outside of the scope of that?
Yeah, that's a great point, Dr. Chastain. This year, we didn't call that out specifically, but there may be enough flexibility within the confines of the request for application to support programs such as that.
Thank you.
Hello. I got this up here. Filling it now. Oh. Okay.
All right. Any other comments about this discussion question? All right, if you think of something later, let me know. We'll go ahead and move on. All right, now I'm going to turn it over to my colleague, Jason Blake, to provide an overview of the Nevada Rural Health Transformation Program. So Jason, please take it away.
Thank you, Melinda. And I want to share my appreciation to this commission and also to Dylan for allowing me an opportunity to give a brief overview of our RHT program. And I appreciate the earlier presenters giving some overview on a big scale as far as the national scale of this program. The Rural Health Transformation Program, if you want to click to the next slide, perfect. The Rural Health Transformation Program initiated July 4th of 2025 as the One Big Beautiful Bill was enacted. There is, over the course of 5 years, $50 billion to be awarded, $10 billion per fiscal year. And all 50 states applied and all 50 states were awarded varying amounts. There were some figures put in place and some allocations. 50% was based on a baseline funding, and then other 50% was based on some workload details there. The middle box there, I just want to focus on that, is this program is intended to make investments in rural health and lead to truly sustainable transformation of healthcare in rural areas. The idea of truly sustainable transformation of health is critical. We as a state, we do not want this money to be here for 5 years and then be gone, and we don't have any long-lasting effects. We don't want to be hit with the fiscal cliff, and so we hope to see great transformational projects brought forward that will last far into the future and continue to provide great service and care to our rural and frontier communities. The next slide can be kind of cumbersome. We're finding as a team that the dates and the deadlines are difficult because we've got federal fiscal year, we've got state fiscal year, and then spanned in between those two things, we have our budget periods for this grant. And so I just want to focus you maybe on two areas. Other than this first budget period, which runs from December 29, 2025 through October 31st or October 30th of 2026, every other budget period will run from October 31st through October 30th of the following year. So keeping track of those budget periods are very important. The other period that I want to pay focus to is the spending period. Spending period is from the first day of the budget period, which is August or October 31st, and it goes through September 30th of the following year. So at the end of the next fiscal period or fiscal year for the federal government. And so those are key pieces there. As you all look through this, if you have more questions, please ask, because I have found myself multiple times confusing these numbers and these dates and deadlines, but we'll try to help you through that. And when I say that the spending period is ending on September 30th of that next year, all monies have to be liquidated at that point. At this point, CMS has not given us any indication of overflow of money or holdover in any of those funds. And so we are going to be pursuing full liquidation by that point. So as stated before, every state put in, and Nevada did as well. We submitted an application requesting $200 million as suggested and requested by CMS. We were awarded $179,931,608 and a significant 42 cents. For this first budget period, we can receive that amount more or less each budget period going forward for this program. That depends on our abilities to use the funds appropriately, make the proper reports, show the proper progress, and so forth. But we have this amount of money moving forward to enact some wonderful projects. We will have to reapply in a non-competitive application each year for these funds as part of our annual reporting process. And just as a side note, because our award was different than the 200 million that we requested, we did have to submit a revised budget, and it was approved on February 19th of this year, so just a little under a month ago. So the Nevada Rural Health Transformation Program is split into 4 different initiatives, and I'll go over these quickly. First is the Rural Health Outcomes Accelerator Program. We call it the ROPE. This is intended for evidence-based, outcome-driven initiatives. Some of the focus areas are chronic disease management and prevention, behavioral health, prenatal care. We hope to see projects that will allow access to the appropriate levels of care. And this initiative will be governed by an RFP process. In the ROPE initiative, we allocated 15% of our total award, which equals a little over $26.9 million for this first budget period. Our next initiative is the Flex Fund to strengthen rural health infrastructure. This primarily is for rural critical access hospitals or rural hospitals and clinics for infrastructure needs. We're looking for entities to utilize regional purchasing strategies, and we hope that will increase the medical transportation access across rural Nevada. That's an issue. From my experience in the rural communities, not only emergent transportation, but also non-emergent. This initiative will be governed and run through RFA processes, and we allocated 20% of our total award, which is little over $35.9 million. The third initiative is the Workforce Recruitment and Rural Access Program, the WRAP. As you can see there, we're looking at growing your own pipelines. We hope to find some opportunities through our efforts in schools, high schools, and in individual communities to build a pipeline of workforce. We also hope to see projects supporting tuition and training supports for different programs. We also want to see programs addressing burnout and isolation and retention of those providers and those professionals that we have in the communities. And we're also looking for incentives for various new rural provider hires. And of course, as we're hoping to see some growth in our rural residency programs. This initiative will be run through an RFP as well as 2 RFA processes. This is the biggest bucket of money in our program. 40% of the funds, representing $71.9 million, is available for this first budget period in that area. And our final initiative is the Rural Health Innovation and Technology, RHIT. Some focuses here is the digital health ecosystem in rural Nevada. CMS has a website or a page to their website talking about the digital health ecosystem, strengthening the interoperability and the cybersecurity and those various technologies that help support the confidentiality and also the processes of healthcare. We hope to see rural health, telehealth infrastructure improve through this, as well as I said, interoperable health data sharing systems. This will be run through RFP processes, and it represents 15% of our award, which is $26.9 million. As a caveat, before I go to the next slide, just as some different extra information, there are a few set-asides that we have set up. First is for the rural tribal health. We have set aside just over $8 million for our 28 recognized tribes here in the state of Nevada. We've also set aside some for the rural veterans health. We have little over $2.3 million allocated there. And in this first budget period, that will go to the Nevada Department of Veteran Services for some of their initiatives. Next is the Rural Corrections Health, and that is the amount of $2.3 million as well. And that will go to this first budget year to the Department of Corrections. There have been questions, and we've been encouraged to open that up in the following years to other rural county corrections facilities, and that may be something in the future. The last one is, and it goes alongside with the governor's initiatives and direction, is we want to see the presidential fitness test brought forward. And so we have put just nearly $1.3 million in towards the presidential fitness test, and that will be awarded in the direction of the Department of Education there. So I think we can now go on to the next slide. I wanted to just focus maybe as an example of what could happen with some of these monies and maybe spark some interest. So focusing on an area that this commission has been focused on is perinatal and prenatal care. And I share my thoughts here from my experience. I've been a hospital CEO here in two of the smallest hospitals in the state of Nevada for 20 years. And so I have a little bit of experience with this, but I also was able to wrangle in my opinion, two of the best rural physicians this side of the Mississippi. They're pretty awesome, and they even gave me a little bit more than 10 minutes to talk to them. But so baseline ROPE objectives, as we talked about before, evidence-based, outcome-focused. The programs need to be sustainable. We can't have the fiscal cliff. There has to be reportable items, qualitative and quantitative. And then these are some of the focuses that we had in our application as the state of Nevada. And I'll focus there on the last one, maternal and infant health. We'll move into the middle column there. Many of our rural hospitals and frontier hospitals have very limited or no perinatal or prenatal services provided. They do have good family practice physicians. They do have good family practice nurse practitioners and physician's assistants there. But many times once a female finds out that they are pregnant, they're automatically and very quickly referred off to another location that would provide those specialty services and delivery. Expecting mothers are often just immediately referred out to these larger communities where they can have that specialty care. As I spoke with these two doctors, they're both willing and able and ready to take care of these mothers, but there's some support issues that come to question for them. Some providers some OBs in the bigger communities, they don't like to have a patient handed off to them in the third trimester or closer to delivery. And some mothers, they don't want to have to transition from one provider to another. So there are some barriers that have to be addressed in this scenario. But this scenario forces extra personal travel, extra expense, more planning and preparation, not to mention more worry. Where I grew up in Panaca, Nevada, most deliveries are in St. George, Utah, and you have at least an hour and a half drive to get to St. George, Utah to deliver a baby. And so it creates a little bit of worry. And it also, this scenario adds increased risks to poor outcomes. Now, some of the ways that I thought that the ROPE projects and the ROPE money could come into play, we could see opportunities to coordinate perinatal and prenatal care between primary care physicians and specialty care for delivery. I know that there are examples of this happening right now. We just need to find and bring those forward. By adding needed diagnostics in rural hospitals and clinics, some of these remote monitoring systems would help. Of course, increasing education and training for high-risk emergency deliveries, also for EMS, so that they can be prepared to take care of these patients in a long trip to Utah or wherever they may need to go. Case management to track and manage the care needs. And then, of course, create other collaborative pathways for specialty services. We've heard about telehealth services, bringing those into place so that we can have a well-rounded team of specialists and physicians ready to take care of the patients. So this is just an idea and some of my thoughts of how the ROPE funding could be utilized to drive great outcomes. We'll move on to the next slide. I know time is short, and so I'll go through this very quickly. Some of the requirements to remember is the terms and conditions of the federal awards flow down to subrecipients. So all the requirements that we have at the state, subrecipients will have the same. Budgets must be pretty particular and include supporting information for all costs. There's not going to be lump sum draws. We're going to have specific documentation showing the costs. The reporting is quarterly and annually that every subrecipient would have to agree to. It has to be quantitative as well as qualitative. And then a key piece in this, as I have mentioned a couple times before, sustainability is a key. These programs must be sustainable after the close of the RHT program. We don't want great things to come alive and then just die at the end. And so we're encouraging everyone that applies to ensure and to come forward with a great plan of sustainability. On the next slide, these are some of the next steps that we have, and some of these steps we've already checked off just within the past few days. My team and we have been working really hard to do some public workshops. We've done a couple of them. They're posted online. You can go and watch us on YouTube. But we now are putting together some technical assistance workshops and webinars. And so look forward to those coming out. Just the other day, we had our first steering committee meeting, and it was wonderful. We convened a group of 15 excellent people that are helping us guide this RHT program forward. It was a long meeting, but very productive, and they gave us some great ideas right out of the gate. My team and I, right now, we're very small. We're a group of 5 people, and we're looking to hire 10 more people here very quickly so that we can keep this momentum moving forward. And so if you know of anybody that is interested in joining a highly motivated team and working on a great project, send them our way. These RFAs for the Flex Veterans Corrections and the tribes, they are coming out this month. Could be next week. They come out, and so we're working feverishly on them so that we can accomplish those responsibilities. The next item down is the RFA. We've made a change coming from the steering committee. We were looking at opening the window of application in March and then extending it all the way through August for a first come, first served type basis. Steering committee gave us some great suggestions, and we are going to break it up into some I guess, application periods. This first period will be 45-day period. And then we'll work through that, through those applications and make awards. And then we will do another application period as needed or as money is available for us. And so that second period and third period may be a little bit shorter, just so that we can make sure all of our processes are done. But this first one will be 45 days. And then our RFP and remaining RFAs will come out March, April, May time periods so that we can make all of our deadlines there. My final little piece here is just to focus over on the left-hand side of the page. There's some deadlines. Pay attention to those. If in this first budget period, it's shorter, and so maybe if there's some planning that needs to be done for some projects or some low-hanging fruit, something acute that can happen quickly, as far as a project, this is a great time for it, but the money has to be spent quickly. Also refer to our website. All this information is on our website, and we update it quite regularly, and it looks great. And we want you guys to have that resource. And then if you want to be part of the listserv, please sign up on the listserv. After this meeting, if you have questions, reach out to us by email, rhtp@nvha.nv.gov. And with that, I will stop talking. There are some discussion questions that we can open up. First is, how can we leverage RHT funds to best strengthen the rural workforce? Does anybody have any thoughts or responses to that? We've
Dr.
got
Walker.
I mean, it seems to me that between the RHT funds and perhaps the GME funding that would be able to triage, workforce development to the rurals. It sounds like, the need for chronic disease management, older populations having children, and the limited access that may be available to rural health. Strong primary care, family medicine can help manage both the prenatal, postpartum, intrapartum, but also the intra-pregnancy period that needs to be addressed. So I don't know if there's any collaboration going on between the GME side that we discussed earlier and the RHT.
There is some collaboration because Melinda has some authorities over both with the GME and the RHT, and so she is working through there. They do have to be separate. The funds cannot be intermingled or overlapped, but there is collaboration between the two funding pots. We want to make this as beneficial for our residents as possible.
Excellent. Dr. Pora?
Yeah, as a pharmacist, when you introduced the ROPE funding, my brain went to how can we leverage our pharmacists that are in rural communities to kind of help with this. And so thinking about things like smoking cessation, hypertension screening, diabetes screening, mental health screening, and referral. I think that there's a potential to leverage those pharmacists that we have maybe a little bit better than we do today.
I agree with you, and I hope my brother, who is a pharmacist down in Caliani, Nevada, is listening to you, so that he can move in those directions as well. So I think there's great opportunity for pharmacies and pharmaceutical services to improve.
Maybe just one other thought. I want to commend the state for and I guess the board for their recommendation to think about cycles of funding. I know oftentimes in these RFP processes, the windows are pretty short. You kind of have to have all your ducks in a row, and sometimes they can be an onerous process. And when I think about some of the things that potentially may be the most meaningful in communities in our rural areas, they may be much more grassroots in terms of the approach. And so thinking about how are there mechanisms through the funding process that will allow for that and have enough latitude for people to really be creative, and supporting the communities themselves in actually delivering on some of the transformation. Because I think in the long term, when we think about sustainability, those are the kinds of things that probably, it's not flash in the pan of some external technology necessarily, or something from outside the state coming in and swooping up funds. It may be those grassroots efforts that actually have the longevity. So appreciate that.
I love your thoughts there. And just to let you know, I've looked at a few other states, and I think ours is the best. Our program is the best by far. But one of our approaches that I love so much is that we are not from the state level saying this is the program, this is how it's going to happen. We have required, and you'll see in our RFAs and RFPs, we're requiring that these ideas and the improvement projects are grassroots founded. That we're pushing everybody to the rural community, saying if you can't come forward with a letter of commitment or a memorandum of understanding, you're not going to rank high. We've also made requirements that for vendors that may come from out of state, even urban vendors, we have made this stipulation that these services and these monies need to be have to benefit rural and frontier Nevada. They can't take the money and go to another state. It has to be here in Nevada.
Awesome. Dr. Peterson.
Yeah, I would just ask for this specific population. I know that there's been discussion around like a pregnancy health home model, and I am not at all an expert in this at all. I just, when you talk about like sustainability, and I'm seeing things like case management, I don't know, has there been any discussion around, looking at building things like that out? Because my understanding is that that's something that would help with sustainability towards some of these projects.
I haven't been involved in any of those conversations at this point. Melinda, have you heard anything regarding this?
No, I haven't, but I think that's an excellent suggestion, and would encourage folks to, consider that type of a model when they're putting forward their application. How can we build that structure in our state, and then think about how we can sustain it after these funds expire.
And Jason and Melinda, I'll just chime in here. I'm Ann Jensen. I'm the Medicaid director here. Andrea, I appreciate the question, and it's a great kind of teaser for something I'm going to present right after this on kind of models that Medicaid is exploring right now, of which health home is one. So definitely appreciate there's connection and value in finding the sustainable approach, and I'm hopeful that we can talk through what that may look like very soon.
Thank you.
Dr. Walker.
Yeah, I'm going to piggyback on Adam Porth here. I'm aware that there are some states out there that have advanced practice models for pharmacists. And I don't know if there would be, and maybe that's something that will be discussed, but if we're talking about increasing workforce, that would be an untapped workforce that maybe we can utilize in this space, both rurally and in maternal health. I don't know if anybody can speak to that.
There again, I think great opportunities are out there. We are, this is a 5-year program. This first year, we're really buckling down and we're trying to sprint as fast as we can, but definitely moving forward, we have opportunities to pivot and to change and to mold this program going forward to the needs of our communities out there in rural and frontier Nevada. So if it's not something that is ready to go right now this year, there are future years. And we do encourage a phased process or a phased planning process for some of these projects. Maybe in this first year is a planning procedure where we get all the infrastructure ready to go, and then years 2, 3, 4, and 5, we put together the program that will be sustainable. And so a phased approach is needed.
Dr. Pora.
Yeah, just to respond to Dr. Walker, current state for pharmacists, when you look at reimbursement for clinical services, it's very much tied to specific activities. So HIV PrEP pharmacists can get reimbursed for medication-assisted therapy for opioids, and dispensing of oral contraceptives are like the 3 disease states today that pharmacists can get reimbursed for those clinical services. So I think that when we think about just what the opportunity is, I mean, if we had that more broadened to say, again, in this realm of chronic disease states, what could those pharmacists be doing to help out? I think that's where the opportunity is.
Agreed. I don't know. I think we're at our time limit, maybe even past it a little bit. There is one last question on there, and sounds like our conversation so far has been regarding some of that conversation. If you have any questions or comments regarding these 2 questions or anything else, please don't hesitate to reach out to us. We'd love to try to answer any questions or concerns or give any information possible. Here's our contact information. Dina Schmidt is not with us today. She's taking care of some other business right now, but she is our program chief, and the 3 of us that are listed here, we should be able to answer most questions. If not, we'll go to CMS and get answers. So thank you for your time today, Dylan. Thank you, and appreciate all the good work you all do.
Yeah, thank you
You
guys
so much for being here and for presenting all that great information and taking the time to pull it all together for us in one place. And hopefully you'll get input from others, not only the commissioners here, but also others on the line. So looking forward to seeing where that all heads. It's exciting.
Thanks.
Awesome. All right, we are going to move forward, and Administrator Jensen will ask you to pull your slides up, if you will. We're going to be looking at an overview of programs, initiatives, and opportunities in Nevada Medicaid. Again, we have about 40 minutes allotted for this. Maybe if we can try to keep it to 35 within some questions, that would be amazing. And this additionally is mostly for information today, but if there are things, we do have it marked as for possible action and recommendations related to BDRs, but we'll bring that up at the end. Thank you.
Wonderful. Thanks, Bethany. I appreciate it. Hi, all. Good morning. It's great to see you. I'm Ann Jensen. I'm the Medicaid director here and excited to spend some time giving a quick overview of our Medicaid program. Maybe familiar to some, but always helpful to start with kind of the foundations of where we are playing a role in our state's healthcare system. We'll talk a little bit about what we're doing here at Nevada Medicaid related to population health and quality and the roles that maternal and infant health play within that. And then giving a quick update on our payment methodologies related to maternity care services and reviewing some benefit gaps and opportunities related to our maternity care and coverage. I will also, in the middle of our presentation, be turning it over to our colleagues at Mercer, who will be doing a quick value-based care 101, which I think will be helpful context and framing for this work. So you'll see a quick handoff in between a couple sections of my presentation here. So as always, let's start with the basics and kind of orient to what Medicaid looks like in our state, right? So fundamentally, Medicaid is a health insurance program that provides medical, behavioral health, pharmacy, and dental benefits to Nevadans who qualify based on their income, disability status, or other healthcare needs. Enrollment in this program fluctuates daily, but right now we're at about 730,000 Nevadans, which is about 1 in 4 people in our state, receive health coverage through Nevada Medicaid. That means our biannual budget is $5 billion in state and federal funds. Importantly, Medicaid is a state and federal blended program, meaning all 56 Medicaid programs in the US, 50 states plus DC and 5 territories, share a portion of the regulatory and financial responsibility for the program with the federal government. In Nevada, that typically looks like the federal government paying about 60 cents of every dollar for our Medicaid program. But it's a really nuanced calculation that varies by service and by person. But importantly, because of that kind of cost sharing method, we are beholden to both federal and state regulations as we run this program. I think that's important context as the commission thinks through what opportunities there may be to expand coverage. Any changes we make to our program, as always, run through the federal approval process, and happy to speak a little bit more about what that represents. What you'll see on the left, importantly, for health coverage on births, 1 in 2 births in our state are covered by Medicaid. Right now, it's about 53%. That's around 17,000 babies born per year that are receiving that health coverage through Medicaid. So there's significant opportunity as a payer in the space to think through how do we alter the ways that we do provide coverage and reimbursement for these services to improve outcomes in those births. You'll see at the bottom here are eligibility limits for the Medicaid program as a percentage of the federal poverty level. So that FPL is a very important national metric that's re-benchmarked every year. Right now in Nevada, kids are eligible for Medicaid coverage if their family or household income is up to 205% of that federal poverty level. Pregnant women, it's 190%, and parents of kids, it's 138% as well. So that's kind of quick context on the population overall here. I think what's so important, there's a lot of questions about what is managed care in our state. And really what that means in our Medicaid world is whose name is on the back of your insurance card. In Medicaid nationally, there's 2 primary types of, or most common types of delivery systems. Those are fee-for-service, in which the state directly manages the Medicaid program, and managed care, in which the state contracts with a private, for-profit or nonprofit entity that runs the program themselves. In Nevada, we have 5 managed care organizations spanning the entire state. That was a legislative mandate to expand statewide, and that happened in January of this year. So there's 2 plans available that in those green counties, as you'll see here. There's 4 plans available in Washoe County and 5 in Clark County. So it's important for this conversation because our managed care organizations not only create provider networks, provide that reimbursement as well as care coordination for patients, but they also have kind of unique access to funding mechanisms to better support moms in our state as they move through the pregnancy process. So they have funds that as a state Medicaid agency, we can't pay for things, but they have what's called community reinvestment dollars and other mechanisms to provide some really innovative and creative models that we'd be happy to kind of touch on more on this forum if the commission is interested. What's also important here, nearly every pregnant woman in our state and baby in our state will be covered by managed care. After January, the fee-for-service population is pretty small. It's about 8 to 10% of our overall Medicaid patient population, and it's primarily people with disabilities, seniors, and youth in foster care. So wanted to provide context on who's in the program, how is it paid for. The last, I think, important context setting here is related to what maternal health services does Nevada Medicaid cover. So again, Medicaid has a set of required services that every Medicaid program has to cover. And then there's optional services that the states can seek federal approval to cover in addition. So what you'll see here is a list of all of the services that Nevada currently receives federal approval for to provide coverage for patients throughout that pregnancy journey. So these include, as always, medical and behavioral health services across the spectrum for moms. Preventative screenings are, of course, available along with reproductive health services and family planning services. Doulas and community health workers are a relatively newer covered service within our program, as are a broader range of genetic tests, nurse midwives, high-risk pregnancy care coordination, and housing and meal supports. Like I mentioned before, the MCOs have that leeway to provide some reimbursement for some additional services. Those last 2, high-risk pregnancy care coordination and housing and meal supports, are both managed care specific benefits. During labor and delivery, of course, the delivery and inpatient stay for mom and baby is covered, as are any LARC services that's paid for separately now as part of that process, along with breast pumps and lactation consultation. And then postpartum, Medicaid has secured approval to provide 12 months of continuous eligibility postpartum, meaning moms don't have to reassess whether they're eligible for Medicaid for a year after birth. So that's one aspect during a very busy and often stressful time that they don't have to worry about. So all of those services are covered for 12 months, at which point they would go through the process to determine whether they still meet the eligibility requirements for them and or their baby to remain eligible for Medicaid. So I'll pause there briefly because those are kind of the overall Medicaid context slides. Any questions on that? Does that feel clear as we kind of move forward and think through what our quality strategy may look like? Okay, seeing nods. So I'll keep moving, but feel free to raise a hand or drop a question in the chat if it's ever helpful. So I'm going to provide a quick overview of our quality strategy before I turn it over to our colleagues at Mercer. We, as a state, have something called a Medicaid quality strategy. And that is a federally required report and process for our managed care organizations. So it has our statewide quality goals, measures, and monitoring processes to make sure these managed care organizations are not only adjudicating the Medicaid program, but they're doing so in a way that improves population health and quality for patients in our state. So quality is measured, as always, that's the devil's in the details, right? How do we actually define and determine quality of care? So this quality strategy relies heavily on national quality measures, so HEDIS and the CMS core set measures. It also includes details on performance improvement projects and a component drafted and written by our external quality review organization, which is a third-party organization that works to assess whether the state and managed care organizations are in compliance with federal law and progressing towards our mutual program goals. So this is an important, very foundational approach to what quality looks like, but it's not necessarily specific to things that we want to be especially focused on in our state. So what we did to address that is establish what's called a Medicaid Quality Collaborative. This is a requirement of every private hospital in our state, as well as our managed care organizations. And the reason why the attendee list is who it is because it's tied to some really important supplemental payment programs that our MCOs and hospitals participate in. And as a condition of those funds, we ask them to come to the table and really be creative and brainstorm with us on how do we improve population health and quality in particular areas of focus. And so this group is, since it was established in 2024, selected 2 primary focus areas. And those are maternal and infant health and care transitions to the community from higher acuity settings, like an inpatient hospital or skilled nursing facility or other types of residential or inpatient treatment. So what the Quality Collaborative does is afford a chance for folks to share best practices, for the state to get feedback on guidance related to value-based care, and to essentially mutually define what the state's value-based care approach will look like moving forward in these 2 focus areas. So before I talk about kind of what decisions have been made so far and where we're headed with our value-based strategy, I'm excited to turn it over to, I believe, Carl and Melissa at Mercer, who will be sharing a little bit more about what is value-based care, what are the words we need to know, what are the terms and the lingo that's valuable before we dive into what those details can look like in Nevada. So Carl and Melissa, I'll turn it over to you.
All right, thank you, Ann, and good afternoon or good morning, everybody. My name is Carl Mueller. I'm a principal at Mercer, and my colleague Melissa Mainen is also assisting with this presentation. And so we're really excited and thankful for the opportunity to do so. And some of these things have already been covered a little bit earlier today, but like Ann had mentioned, kind of going over key terms. So next slide, please. And so these are common terms just to make sure everybody's on the same page in terms of vernacular, just kind of reading from left to right. Value-based purchasing, that's the broadest concept here. First, any strategy moves payment away from fee-for-service towards rewarding quality, outcomes, and efficiencies. And then alternative payment models, APMs, those are specific payment arrangements. And then moving to the right, episodes-based payment, I will say in my past work life working with Tennessee TennCare, I have deep experience with the perinatal episode of care. So it's nice to see the conversation going, but that's what that is, perinatal episode of care and TennCare that was talked about earlier today. And looking at population-based payments, those are payments that are focused on managing the health of a defined group of patients. And providers are responsible for meeting quality targets and managing overall spend for that population. You move to that kind of bottom middle, provider accountability. Many of these models increase provider accountability in terms of cost and quality outcomes, and through the objects of data sharing, care coordination, and performance monitoring. And then the kind of bottom right you see there, value-based care, that's the clinical care delivery approach itself. It focuses on quality outcomes, and care coordination. And payment models like VBP, payment models like APMs are tools that encourage providers to deliver value-based care. So in simple terms, just kind of broad brush this, value-based care is the goal, VBP is the strategy, and APMs are the payment models we use to get there. So next slide, please. And just to kind of connect the themes, that's what you see here in this graphic. So VBP at the top, value-based purchasing, again, that's the overarching strategy here. APMs, those models, those are the contracts or payment arrangements that are used to implement VBP. And so these models determine how providers are paid and how those incentives are structured. And then you can see that purple circle, P for P, pay for performance, that's an example of an APM. So you kind of see kind of the structure and the tier of this. When we think of concept, think of implementation, and we think of the model itself. So this slide shows that it's layered, and it shows kind of a specific payment example. So next slide, please. And so this slide, VBP, who does what, we look at the purchaser role, the health plan, and the provider role. So now we're talking about from concept, now we're moving towards the stakeholders involved in the process of this. And so the purchaser role, purchasers are typically state Medicaid programs, employers, or government agencies, and their role is to set the vision, the priorities for value-based care, define those quality measures and expectations, and establish those payment structures and incentives. The health plan's role in this, for example, acts as the operational partnership, the operational partner that implements these strategies. And these responsibilities include, managing the contracts with providers, supporting providers with data and education, and administering those incentive payments. Again, every VBP model is different, but this is a high-level overview. And the provider role is the one delivering the care, seeing the patients, implementing the clinical changes needed to improve quality outcomes. And their role is transforming care delivery, improving quality, and engaging those clinicians and patients in care improvement. So the key takeaway from this slide is that successful VBP depends on alignment across all three stakeholder groups. Next slide, please. So we're going from the concept, but here's kind of a foundational reference, the Healthcare Payment Learning and Action Network Framework, otherwise known as the LAN framework. This gives you a sense of that continuum as far as moving from the far left, fee-for-service, which is used widely across the country, into that more traditional connection to quality and connection to value itself. So I'm just going to very briefly kind of go from left to right. Category 1 is traditional fee-for-service. There's no connection to quality or value. Providers are simply paid for each service delivered. Category 2 still uses fee-for-service, but introduces incentives tied to quality or reporting. So that's what you see there with the Category 2A, B, and C, different variants there. And you can see where P for P falls is a 2C model, just to connect it from the previous slides. Category 3 introduces shared financial risk. Providers can earn savings if they reduce costs while maintaining quality. And some models also include downside risk, meaning providers share in the losses if costs exceed targets. And it could be cost targets or quality targets. And you go all the way to the far right, Category 4 represents the most advanced models according to the LAN framework. These include population-based models such as capitation. Providers receive a fixed payment to manage the care of that population. And like I mentioned earlier, it could be a specific population, such as maternity, perinatal. So key takeaway here is that as we move from Category 1 to Category 4, providers take on a greater accountability for the cost and quality outcomes of the patients they see. Next slide, please. And so this is, so you see kind of how almost kind of transposing the LAN framing. So you can see that progression, right? So it's an example of how payment models evolve along a continuum. So again, on the left side, you see that fee-for-service kind of existing, no or very little value-based in and of itself. And you see the early steps going from Category 2, kind of the red graphic there. Primary care incentives, performance-based contracts, quality incentives still rely on fee-for-service though in that red, those two red bars there. And you kind of have the mid-stage models when you get to the purple. And like I mentioned, that could be the perinatal episode of care, bundled payments. You see those things come up, and providers are held accountable for the total cost and quality of a defined episode of care, for example. And as you get further up, you see that more advanced model, shared savings, shared risk models, where providers manage the cost of a population and share in the financial outcomes of that population. And that far end, like I mentioned earlier, is capitation, where providers receive a fixed payment per patient to manage care. And this model creates the strongest incentive for prevention, care coordination, and efficiency. So kind of in closing, the message here as you see this progression is that value-based payments is not a single model. Instead, it's a progression towards that greater accountability, greater provider accountability for cost and quality outcomes. And with that, I'll pass it to Anne. Thanks very much, guys.
Yeah, thank you. I know our value-based care world can be a little bit wonky, so I appreciate a very clear explanation of what it means, and I'm glad the commissioners can get access to these slides after the review. I know a refresher on what do we mean by all these acronyms is always helpful, so thank you for that framing. What I'll talk about here is what can that look like here in the state of Nevada. So we have developed with the Quality Collaborative team and feedback from our community a value-based payment roadmap that really demonstrates where are we right now as a state in our work within value-based care, and where are we headed, and how does that tie to the kind of overall land framework and broader national conversation on value-based care. What you'll see in this roadmap, which is available on our website right now, it's a focus on fostering alignment across all of the Nevada Health Authority. So the beauty in Nevada, Medicaid covers 1 in 4 people in our state, but programs within the Health Authority cover 1 in 3 in total, with the addition of the exchange and the public employee benefits program. And so we're really focused on how do we learn quickly in Medicaid and leverage those learnings to broaden our value-based care approach across the entire spectrum of health coverage in the Health Authority, because ultimately that leverage makes negotiations with payers more reasonable to support the program goals, and also helps our providers. It simplifies the administrative complexity of these programs. My background actually before my work at Nevada Medicaid was in value-based care, and I supported independent primary care docs directly in how to be successful in value-based care arrangements. And one of the biggest things that you can do is make the quality measures that you're measuring easier. Measuring 87 different things is not actually very helpful or a good way to drive population health. Really honing in on a really core set of measures that you actually want to move the needle on are absolutely the right way to go. And that's what we're focused on here at the state. So what you'll see is we're developing contract requirements for our managed care organizations to develop VBP arrangements with hospitals, specialists, primary care docs, nursing facilities, and other forms of providers across our state that meet state guidelines and requirements. And what that can look like is they have to use quality measures that are selected within our state kind of menu of measures. And that's intended to really make these models a lot easier for providers to participate in, and also easier for our managed care organizations to administer. And so these VBP arrangements can change over time. Our intention is it will be tailored to where a provider is at in terms of their administrative ability to take on a value-based care arrangement. But the goal will be to move all providers along that land framework to more mature risk-bearing arrangements over time. So what you'll see here in the realm of maternal and infant health, this is what we're focused on with the Quality Collaborative. 2 types of value-based payment models that follow that same general structure. Firstly, it will be a hospital quality partnership that'll kick off more formally in this state in January of 2027, in which managed care organizations will contract with birthing hospitals to improve quality and care coordination during labor, delivery, and immediate postpartum period to ensure successful quality outcomes and transitions of care. So those quality arrangements will have to be at least pay for performance or higher on the land framework. It will, again, be a contract between MCOs and birthing hospitals, but it will utilize the quality metrics that are established by the state based on feedback from our broader provider community. We can appreciate our hospitals play an important role, but not the only role in maternal health outcomes. So we're also coupling that with a pilot program that will kick off next year, related to community maternity care providers. So folks that aren't doing the labor and delivery component solely, but are part of the prenatal and postpartum care continuum, and establishing similar pilot programs between the MCOs and those providers along some form of that land framework you'll see listed here to test out what type of model may work best to scale statewide. So as I mentioned, that quality measure set is a really crucial thing. We'll come back to this in our discussion questions, but I want you all to see we're really focused on a couple different kind of flavors of quality measures. First is process measures, measuring did a process take place, or are we headed in the right direction with our kind of clinical process steps? The second place is the long-term outcomes of our care. Are we getting in the direction that we want to see? We also recognize to be successful in value-based care, we really need clear structural components in place. And so those structural measures are a little bit broader, and they're a little bit maybe squishier around the edges, but they're focused on ensuring, do we have an evidence-based discharge process? And do we have clear behavioral health screening and referral processes established to ensure that the full component of clinical care being delivered aligns with evidence-based practice here? Because we all believe in combination, the structural requirements, the process measures, and the outcome measures will work together to result in a value-based model that drives the outcomes that we want to see. You'll see here that maternity care provider pilot program, those quality measures are still under development because we're having ongoing conversations with community providers. So you won't see anything listed here. The ones on this slide are essentially our final draft measures for our hospital value-based program, again, between MCOs and hospitals. So I do want to touch before we close and open it up for discussion on a pilot program that 2 of our managed care organizations conducted with a couple birthing hospitals in our state during 2025. So the state ran what was essentially a bonus incentive program for our managed care organizations, in which they were asked to develop pilot programs in maternal health and care transitions with hospitals in their network to essentially test some value-based strategies or some really basic kind of pilot programs that we think may be helpful to move the needle. This is a really exciting one that's focused on addressing low postpartum visit rates, which in our Medicaid program in particular are well below national average or any clinical rate that we'd like to see in terms of moms getting care after birth. And so in partnership with the birthing hospitals, these 2 MCOs worked to adopt a standard discharge workflow with the hospitals to schedule postpartum visits before a mom left the hospital. They got essentially a little packet of information that included a postcard that could be kind of taped to their fridge that had some reminders of, here are symptoms to keep an eye on after birth. If this happens, here's what you do. Here's the direct number you call, as here's the postpartum visit date and time that you have scheduled, all of those really basic details that can just be top of mind and in a very visible place in their home. They also connected moms to care coordination and broader supports that the MCO provided. Things like transportation to and from that postpartum visit, or access to healthy, nutritious food, or a housing deposit or utility deposit to help them ensure they could remain living in a safe place. So all of those kind of wraparound services were developed in a more standard process with the hospitals. And you'll see in the dark blue some pretty significant increases in postpartum visits actually being completed with this pilot program in place. It was really exciting to see these outcomes. Again, this is the result of just about 4 months of work. It's very small. It's thankfully ongoing in this year, even though the bonus program has ended, the MCOs and hospitals are continuing this work. And we're excited to see these types of models continue to scale across our state as both hospitals and MCOs will see more financial incentives with outcomes just like this. With postpartum visit rates increasing, you would see more money going to our providers and MCOs, and that's exactly the model that we want in our value-based approach. So before I close, I'll kind of give a timeline of where we are and where we're headed with value-based care. Right now, 2026 is really laying the groundwork and getting feedback from our stakeholders on what this can look like. The requirements for those value-based payment models between MCOs and providers go into effect in January of 2027. And so this year, we're really ensuring that contracting guidance is clear and will be published very soon. So that way our managed care organizations and hospitals have significant time to work through the negotiations and details of what those contracts will look like. And we'll continue to expand and refine those in the years ahead and expand beyond those two initial focus areas. Our kind of priorities 3 and 4, as of based on feedback and votes from that quality collaborative, our behavioral health and primary care, which I know are near and dear to this full group's heart. So look forward to more kind of an expansion of the focus of these programs. Through this time, our hospital state-directed payment is a supplemental payment program, and that is ongoing. It also includes a range of quality measures that are really directly tied to this work. So we hope we're kind of hitting this from a lot of different angles, and we look forward to seeing the results of these efforts. So with that, I'm going to open it up for discussion on our value-based payment approach. Acknowledging I do have some slides related to reimbursement methodology and benefit, kind of our overall Medicaid benefits for maternal health and where there may be opportunities. So I want to make sure that we get through those in what is, I know, a short amount of time. So we'll open it up for brief discussion on the value-based payment approach. Any feedback on those current maternal health measures for the hospital program you all would like to share, or anything related to the long-term direction that you want us to keep top of mind before we move forward?
Maybe more of a question, and if you might, just curious on, as you guys are beginning to see some of the preliminary results from those value-based contract efforts and some of the pilot work, how will that be shared, or is there visibility to any of that? You know, not maybe with like all the detail, but just at the kind of roll-up level to understand, are there any learnings from it and ways that we can think more broadly about the impact of that?
Yeah, it's a great question, Bethany. Short answer is yes. So there was a lot of detail shared by our MCO and hospital kind of pairings in the quality collaborative meetings, which I recognize are specific to that group, but helpful for kind of peers to hear each other's work. We also have presented some of this at our Medicaid Advisory Committee and Beneficiary Advisory Committee meetings, what's called our MAC and BAC meetings. So a broader set of providers and current Medicaid members can give feedback on these programs. And I anticipate that will continue. But that's a good note that we should consider to think through. Maybe at the end of this year, we can set up time with our MAC and BACs on the agenda to give them updates on what's happening and get feedback, and also share more broadly what some of these outcomes look like.
I'm just thinking too, some of our hospital partners may, like some of that data may be helpful and insightful to them as they're thinking about setting up different programs and the infrastructure to be able to do well in these types of programs, and having sort of one spot that they can go to look at some of the data and understand some of the insights from it might be helpful.
Yeah, no, it's a good suggestion. I think the Quality Collaborative will be a great place for it, and the hospital associations also host, I believe it's monthly quality meetings, and so we work closely with them on what data can be presented there and shared with each other. But good thought on, are there other ways, even like a dashboard on our website or other forums for folks to be able to kind of self-serve some of this information? So we'll take that back and think about how we can do that better. So thank you.
Other suggestions or feedback from commissioners?
Right. Yeah, Dr. Chastain.
Thank you, Anne. I think we've heard a lot in previous discussions about things like perinatal quality collaboratives, other advisory groups, and I think something like that might be helpful, in guiding measurement definition, and particularly in selection and ongoing evaluation, right? And offsetting some of that effort to kind of make sure that we're still in line with what's recommended. So just a thought with that.
Yeah. I appreciate it. Yes, I think that's the crucial piece. Is it's not only setting these benchmarks, but it's evaluating, are we heading in the right direction, and is that a very clear, is those the right measures, and are we acting quickly on what results we're seeing? So appreciate that comment, and look forward to our continued work to find the right way to do it. So, yeah, Commissioner Kirkpatrick.
Thank you. So I have a question. So we're only one piece of the bigger vision going forward. So is there a vision that you all think that we need to be looking at? Because I think of all this infrastructure money. I think of we've talked about this topic in 10 different ways, right? But I don't know where's the collaboration. So there must be like a core place of where you want to get to and what everything can do, right? So, and what I feel is missing when we talk about workforce, there's no housing. If there was housing in Elko, we'd be in a different spot, right? If there was housing in White Pine, we'd have that. There is no college opportunities in Lincoln County, right? So and I also sit on NACO. So we're trying to help because we want to help them be successful and sustainable, because what happens, and we've seen it specifically with COVID money, it was so much all at once. And then how do you put it all together so that it lasts, right? And now what we're seeing, quite frankly, is even in Clark County, there are so many nonprofits coming asking for money because they built this practice on 9 new employees and all of that. So I feel like maybe you gotta tell us what the core, where you want to get to, and what is the GME task force doing, right? What is the NACO Health Transform thing doing, so that we can, I need a diagram to see what everybody else is bringing to the table to know where I fit in, because I feel like in my mind, this is typical Nevada fashion, right? We're all having 1,900 different subcommittees and we'll get nothing done because everybody's talking over each other. So sorry.
No, I appreciate the comment. And I just want to make sure I'm totally understanding the angle that you're asking for here. Are you asking the overall vision for maternal health specifically?
I'm asking, yes, what does your agency, you see it most, right? You're evaluating the claims, you're evaluating all of these other things. And what are you seeing as the issues? And it's great to ask us, but I mean, where are the gaps that you're seeing? And how do all these other subcommittees fit into this?
Yeah. I think what you're asking is really on the broader maternal health strategy. And that's where I see our Nevada Health Authority as a whole taking a strong leadership role. It's a key part of our strategic plan, and it really outlines in depth what that can look like. In the interest of time, I think we could probably have a whole conversation on that. And I appreciate the need to really connect the dots of where all these conversations are happening in silos. Would be happy to think through what the role of PPC is in doing that. I think fundamentally, as a state, our vision is stronger access to prenatal and postpartum care in the community, and high quality care delivered throughout labor and delivery that supports the entire needs of our families, right? To your point about social needs and housing, we need to be as broad as possible in thinking about how to support families in our state, and that requires a really comprehensive approach. So I'll connect with our executive officer, Dylan, on how we can really think through a way to show how all the threads come together, whether that's a visual or some other component. But I appreciate your point. Ongoing siloed conversations aren't getting us anywhere. And so kind of making almost like a resource map of where is all the pockets of the work happening, where all the pockets of authority and kind of levers happening to achieve that vision of healthier moms and babies across the whole state. Is that helpful?
Yeah, and I think that's something that we want to include in our semi-annual report, is something like an asset map or a resource map.
Excellent. Dr. Walker.
Hi, thank you. And this question is probably going to lead to work that's needed on this commission, but I guess my question is, in order for many organizations, many providers to be successful in value-based care, really the framework that we operate in within Medicaid is determined kind of by the structure of your organization. I work for an FQHC, and we work in an integrated model. CCBHCs do the same, but we operate under different chapters of the Medicaid Services Manual. And then other entities outside of, CCBHC, FQHC have other rules that apply to them based on those chapters. I can really see differences between covered services between the different chapters. Is there any work to allow more integration by maybe making those services that are covered more uniform across the different chapters?
Question, Travis. So just so I'm super clear, the chapters you're referring to are the FQHC chapter and the CCBHC chapter?
Well, and then even if you're not in an integrated platform like a CCBHC or FQHC. Like we talked extensively about behavioral health in chapter, I think 400 that is, and how those would integrate. And there are some differences in what are covered services among those different groups.
Yeah.
I see success really being from a lot of this integration that we've discussed in this meeting and the last meeting about integration of, you know, pediatric care, primary care, maternal care, behavioral health care. And if there are barriers that we could eliminate by trying to make some of those coverages more uniform.
I appreciate that. I'd love to have a broader conversation with you on that piece. And so maybe Dylan, we can think through whether that's in this forum or another one, but I'd love to get your feedback on where you see that disconnect, because that's a goal that we share, is how do we find broader integration of our benefits coverage, and how do we ensure that folks that are billing for them are able to bill for them. It's a more comprehensive set in alignment with those federal and state regulations. So I think the collaborative models that we're thinking through on our end, including, Andrea, your reference to the health home model, is a great example of that, right? Our kind of siloed system where we divide medical or behavioral health is not realistic or appropriate to the care that each one of our patients deserves. And so how do we get more creative with what those interdisciplinary teams can look like? So I'll touch on some of those models briefly in my slides moving forward, but Travis, would love to connect to Dylan. Maybe you can connect us offline on where you see further opportunity based on your work on the ground. And I'm really grateful for all you're doing to really identify where those integration opportunities remain.
Thank you. I would appreciate that.
Sounds good.
All right, I'm going to keep us going because I think we have about 5 more minutes. Any additional things? I think we have a few more slides. Yeah.
Yeah, I'll go fast. So thanks, Stephanie. I appreciate it.
Yep.
I'll just touch on briefly. As I mentioned, Medicaid is the single largest payer for labor and delivery and birth services in our state. And so we have an opportunity to think about how do we pay for them and how can that align with the outcomes that we want to see. Just teeing up, there will be a much more extensive conversation on this in the future meeting. We're working with a national partner that has a lot of expertise in looking at Medicaid reimbursement for maternity care, and is helping us think through what options we may want to bring forward in a future legislative session to reform what some of this can look like. Right now, though, at a high level, we have what's called a bundled rate, and that's pretty much a single payment that covers the range of care delivered, prenatal, labor and delivery, and postpartum. It's intended to limit administrative burden for providers so they're not having to bill numerous times. The challenge is we don't always see what services are being delivered, and often some incentives get disaligned or misaligned when we're trying to ensure that things like a postpartum follow-up visit are actually occurring. So our MCOs are required to meet or exceed our fee-for-service fee schedule. So there's pretty consistent models used across our state right now, and that's what we're looking at, identifying ways to improve moving forward. So I'll just tease a lot more, a chance to discuss this, and I'm excited for this group's input on how we move forward here. I'll also briefly touch on Medicaid benefit gaps and opportunities. What's in white above are some more enhanced services that we've more recently added as part of our managed care expansion. So high-risk case management, more tracking and clarity on what wait time standards are for prenatal care appointments, childbirth education, and infant care and parenting education. In blue, though, are things that we don't currently cover, but if we had the legislative authority to do so, may be valuable for the state. So these are things that if the commission's interested in, we can touch on this. Lactation specialist services, midwifery support, home visiting, fertility treatment more broadly, and pregnancy health home model. So Andrea, I know that's of interest to you. I'm happy to have a follow-up conversation offline as well on that piece in particular, but a lot of creative models other states have taken. And this slide really shows, here is kind of how Nevada stacks up with some of these Medicaid best practices nationally. So happy to speak to any details there. I want to be respectful of our final presenters on the agenda, so I'll keep moving. But I think there's a lot of further opportunity for collaboration across the state. I think Commissioner Kirkpatrick, this kind of speaks to your point. We can do better in connecting all the dots internally in our state to improve this. I'm super excited to announce, since we even sent out these slides, we actually have officially been selected for a federal state technical assistance cohort on maternal and child health. So we'll be working with our colleagues at the Department of Public and Behavioral Health, across the Health Authority, and the Children's Cabinet to improve the way that we deliver maternity care and learn from some peer states on their best practices too through a year-long cohort, which I'm really excited for. So I'll leave us here on terms of opportunities for the PPC related to supporting BDRs to address maternity benefit gaps within Medicaid, continuing to advise us on those value-based payment models and what our long-term directions can look like, offering input on future models if and when we get legislative approval. How do we actually implement them in a way that makes sense for our state? And then identifying any further things we're not thinking about, but maybe valuable from a statutory or policy change perspective. So I apologize to throw out a full list right here before we close, but want to be respectful of time. So with that, I'll open any final questions from the group. But otherwise, my contact information is here. Feel free to reach out to me directly anytime, and I would love to connect. I just want to thank you all for your service to our state. I know this is a lot of information we're throwing at you, but it's really, your input's incredibly valuable, as is your time. So thank you again for being here.
Thank you so much, Anne. I do have one question. Is centering programs covered under Medicaid? No.
Yeah, I love the centering model. So it's not a directly reimbursable Medicaid benefit through the fee-for-service program right now. Some of our MCOs, I believe, are utilizing that model through some of the work, but I'd have to get back to you on exactly what that looks like and what any additional kind of opportunity to expand coverage may look like. So we can take that one back.
Yeah, maybe when we're talking more about the reimbursement side, that would be interesting. And then the other thing I was just going to throw out there, I know too, especially when we're thinking about that value-based care models and all of that, a lot of times there is infrastructure needed, right? And a lot of that infrastructure isn't necessarily reimbursable per se. And so I just think, like, as you're thinking about some of those new models or even reimbursement methodologies, are there ways to sort of, I'm going to call it pre-fund some of that, but tied to the infrastructure needed to be able to support, again, a more sustainable model over time of providers, hospitals, and others being able to really do well in these types of programs? So I think it's a gap that exists today.
Yeah, it's a great question. I think our Medicaid, the regulations of our Medicaid program pose some constraints on what those infrastructure grant kind of opportunities look like for us to use kind of broader federal funding for it. I think this is really, speaking of connecting the dots, right? Programs like the Rural Health Transformation Grant and other kind of functions may be really helpful as kind of pairing ways to develop some kind of more robust infrastructure work. Our MCOs also have an opportunity to help providers in that way as well. So I think we need to get creative on what that can look like, because you're right. We can't just say, go forth and be in a value-based care model. Everyone needs a support, training, resources to do that. And how do we find ways that can effectively make that happen?
Awesome. Thanks for all your work and creativity. And again, for the great information. We look forward to some more conversations with you.
Yeah, likewise. Yeah,
Thanks
for having me. Really appreciate it.
Awesome. We will continue forward. We have Dr. Brian Ireye. That's probably not how you pronounce your last name. I apologize. From the High Risk Pregnancy Center, and he's going to talk about challenges and opportunities to improve obstetric outcomes. And I think we're probably at about the 30 to 35 minute mark here for your time. And so I know that may be a little bit quick because I know you have a lot of material, but we're excited to hear from you.
Yeah, I have a lot of material. I'll try to be brief though on certain things and flash forward when I can. Just want to go over a little bit of my background. Board certified in maternal fetal medicine, been in Nevada for 30 years. Was the past president of the Society for Maternal Fetal Medicine in the United States, and was our Lifetime Achievement Award winner, which I called the Old Man Award that I got a while ago. Still active in research, doing things, preterm birth, cesarean reduction, and wrote the Key Quality Measures paper for our society in the United States. Currently, I'm the president of a women's healthcare organization here in Nevada that's value-based and functions as a maternity medical home model right now. Briefly, looking at this overall, what I want to say is we are behind in Nevada in regards to maternal and neonatal morbidity and mortality. If you look at it overall, we are basically, sorry, I've got a thing on the middle of my screen. If you look at the maternal deaths, Nevada is slightly ahead, and also we share the same poor disparities in African American births in terms of maternal mortality, and also in neonatal morbidity and mortality were very much equal. And most of us would say that's behind in comparison to the rest of the developed world. Sorry. If you look at the preterm birth rate, so overall, Nevada is 11%, which is a D on the March of Dimes report card. The United States was a 10.4%, which was a D plus. But I think what stands out most about Nevada is if you look at our surrounding states, they're much lower than we are overall. And so I think we have some maternal and neonatal system challenges, and we have unfavorable outcomes that I feel are very much preventable. We have these high maternal mortality rates, and morbidity is 60 times higher than mortality. And then we have these persistent inequities in both maternal and neonatal outcomes. And then when you look at the neonatal outcomes, even worse, we have elevated preterm birth rates driving this even more. So I think overall our core issues, we kind of continue to underperform on measurable maternal and neonatal indicators. I'm going to get to most of these overall, but just to prime the pump a little bit, I think we have a problem with system governance and quality infrastructure. We don't have a perinatal quality collaborative, and that leads to kind of a gap in leadership. We have some access issues with decreased amounts of obstetrical providers and problems in rural areas. I think we have some fiscal kind of misalignment in spending. In Clark County or in Southern Nevada, not in Northern Nevada, but in Southern Nevada, we have this neonatal outcomes issue with NICU deregionalization, meaning that everybody has to have a level 3 NICU, and that makes basically the experience level of our NICUs worse, which makes outcomes worse. I think we don't look at the easiest thing to probably fix, which is social determinants of health. And the upstream effect that they have on outcomes. And then, we've been talking about value-based care. I think we have very poor incentives that don't align with our priorities. My goals today are kind of to show you there is a path forward. I think there's some solutions together that we can intertwine to show how we can build upon them. And I'm trying to convince you not only by outcomes, but by cost and ROI. And then at the very end, I want to show the difficulties of value-based care, because I am nationally recognized in value-based care throughout my society, and how it requires careful thoughts to prevent avoidable complications. So 3 principles overall: maternal and neonatal morbidity and mortality can be reduced, and quite a bit so, I believe. Preterm birth, I think, should overall be thought of as a preventable outcome, and we need a thoughtful spending push to get to appropriate outcomes, which will then drive savings. What's a quality collaborative? We need to have one, but it's a statewide team working to improve care of pregnancies, identifying challenges, and PQCs are needed to increase quality, improve outcomes. And due to our worsening problems and racial disparities, I recommend this needs to be a mandatory participation for hospitals going forward. We're one of only 2 states in the country without a PQC, the other being Oklahoma. And PQCs are these quality collaboratives are really implementation engines. They take evidence-based bundles and make them readily available and happen in hospitals via protocols that do not differ from place to place, providing training, data, feedback, education, and coaching. And why is implementation so important? This is one of my favorite papers. It's a paper from 2000 showing that the time something becomes standard of care, how long does it take for it to become implemented at least 50% of the time by physicians? 17 years, okay? And this problem is exacerbated even further in obstetrics because we have smaller groups where dissemination of information is much more difficult. So PQCs would really help us in this realm. And if you look at PQCs in the past, California, they had a PQC that reduced maternal mortality by 21%. You have Illinois that had a 27% reduction in severe maternal morbidity with a hypertension protocol. Ohio's PQC reduced elective deliveries prior to 39 weeks. And even getting all these outcomes, they further decrease cost. And I've now testified before the legislature after doing this in 26. I've testified before the legislature 4 times. And I like to say we're on the lonely road. In 2019, we were one of only 14 states when I presented it. And that's when I was president of our society. In 2022, there was only 3 to 5 states. In 2024, there's only 2 states. It still is that way. Nevada and Oklahoma are still the only places that do not move forward. So we're definitely an outlier in this national standard for maternal and neonatal safety. And this isn't a political statement. It's just a statement of fact. It's supported by CDC, HRSA, ACOG, SMFM, state health departments everywhere. 96% of the country uses PQCs to reduce preventable harm, and they're just no longer innovative. They're basically standard infrastructure that Nevada does not have. And then when you look at it, they also, although they have a cost, they basically save money. And how do they save money? By reducing maternal morbidity, which is costly hospital stays. They reduce maternal ICU admissions. They decrease NICU length of stays, and they decrease litigation issues for hospitals. All of these are pretty well documented, and they decrease cost. The cost of a PQC overall, just for the personnel, though, in the first year is going to be $550,000 to $700,000. And this is where, if it's not funded appropriately, it will basically kill the PQC. And you really need a director, an MFM person that's part-time, a program coordinator, a data analyst, and you need some administrative support because you got to get information out to all of these hospitals. You have to have listening kind of visits to people, and you have to find out where the issues are to be able to put the protocols in place. And then you have the non-labor costs as well, which drive this up to maybe in this first year being around $1.1 million with travel, meetings, and training. You really need the data systems and the technology behind it, because that's where you get into these plans that do study act cycles, basically, or PDSA cycles, where you really move things forward. And then you also need some legal compliance and overhead. So people will balk at the cost of a PQC. But if you look at it, California's Maternity Quality Collaborative put in OB hemorrhage protocols, saved an estimated $9 million. And if 50% of that comes to Medicaid, that's a massive savings for the state. North Carolina saved $98 million over 11 years, which is a 925% ROI. And Ohio's just early elective delivery reduction was its cost savings of over $28 million. I basically have said before the state, what we should do is we should make this, because the money savings go to the payers because they are paying out less. This should be a fee that goes to the payers itself. If you have 32,000 deliveries a year at $40 per delivery paid by both Medicaid and commercial entities, that's only about 0.2% of the total maternity spend overall. And I think it's unfair to ask hospitals to do this or providers to make payments to this. And the reason is they have to go through the education. The hospitals have to go through the quality improvement staff time. They have to get personnel to do it. And this time and other personnel are costs to them as well. I've kind of put together the ROI of this, utilizing some artificial intelligence, and I get a Medicaid savings somewhere of about 0.8 to 2.2 million per year. You get a commercial savings rate of about 1 to 3 million per year. And that's mainly through kind of fewer catastrophic events and reduced malpractice exposure. Patients are going to get safer deliveries with reduced preventable complications and more equity, because you get more equity, both rural and racial equity, due to putting protocols in place that treat people as having their conditions to be the same from person to person, which makes the care more standardized. And then the state of Nevada will get this beautiful public health infrastructure with long-awaited alignment with CMS and data to be able to move forward. So, I think the payer payment for it is going to be somewhat controversial in this, but this isn't a hospital tax or a payer tax. I like to think of it as a per delivery maternal safety infrastructure alignment, aligned with who captures the savings. It's a small investment, 0.2%. The payers fund the collaborative because they capture the savings of the improved outcomes of the collaboratives, and the hospitals participate because they capture the safety benefits. And the providers and hospitals provide the heavy lifting of the meetings, the data collection, and the educational efforts that go forward. So everybody puts something into the game. And just before I went before the state to do that, I asked the society to give me a letter, and they did better than that. They gave me 6 people signing on to a letter that we need a PQC in the state, and this was submitted to the legislature. I also want to talk next, kind of switching gears, I want to talk about the hidden care challenge we have. You know, most of the important impacts that we have in care are from people who unfortunately are living in the shadow. They're hidden by patients, they're not discussed by providers, and there's very poor alignment with payers. And that's social determinants of health. If you look at the infographic on the right-hand side of the slide, the physician themselves are only about estimated to give about 20% of the total outcome by what they do. Almost 60 to 80% is driven by outside forces, and those are the social determinants of health where people live, work, play, access health, etc. And it's their quality of life outcomes and risks that are associated with it. Those main issues are access to care, transportation, food insecurity, weak social support. And I think, and housing, I didn't put on there too, but an upfront investment in social determinants of health will really give long-term savings in preventing preterm birth, NICU, hospital visits, and prolonged admissions. And let me show you an example. Just using housing as an example, people with housing instability have 20% higher rates of preterm birth, 60% higher chance of prolonged hospitalization. If I get a person with a that has a housing issue and they're in the hospital for a specific problem, it's very hard for me to discharge them because they have no place to go and their outcomes become worse. And they're 170% more likely to visit the ER within three months of birth. So these are very challenging problems that we have moving forward. And we really have a poor understanding of the true magnitude of these problems because these problems sometimes are episodic. They're not volunteered by patients because they don't think you care unless you ask. Medical coding has only recently come out for these, and they're optional, and they really don't make sure the doctors don't have to code them. And people don't do consistent screening, and it's non-standardized. So patients end up underreporting because they don't see there's clear benefit. And the health systems, for the most part, separate the medical and social data, and this prevents us from having a real population-level analysis, which hides the association. And I think, you know, the public attention is focused on mortality because of what we've done in the United States, but morbidity is much more common. So I think there's some solutions, and I wanted to put to you on the side, like the codes that the doctors have to go through and look for. I mean, this is difficult, you know, to find the proper codes. And I think you don't even find these codes if you don't screen. And so I think what we really need to do is we really need to consider a statewide screening program for pregnancy and social determinants of health. And I would recommend embedding that also into the Medicaid managed care contracts. And then that would make the MCOs the engine for these social determinants of health screens. And then once they get these screens, they could help with submitting data for Z codes so the state knows exactly where we're going with this and how big of a problem it really is. But I think this shouldn't be just a screening issue. It should also, we should close the loop on this with navigation, because a lot of the MCOs have these navigation sites that you can go to or you can call them, but they aren't centralized. All right. So what happens is you have to make a specific call. You have to try to get the person the care, and then you don't know what happens afterwards. I think all of the MCOs should have all of their information on a single site, a central site. So where a provider does a screen, they know where to go to the patient, and then the MCO types them back on what they've done for the patient. I think that would end up closing the loop and allow a lot more doctors and midwives and advanced practitioners to get their patients into some solutions that the MCOs already have, but we're just not aware of. And I think the central infrastructure is important to drive uptake. and it will help us get some state reporting dashboards on this. And then as a practice, you only do three things. You screen, you send the e-referral, and you get the documentation from the MCO back on what they did to help the patient in regards to that. I think that would be a huge help. I can tell you in my office, we put a social worker into our office about 8 months ago, and we started screening every single patient for social determinants of health. And I'm just shocked by how many people that I never knew didn't have housing, couldn't pay for their next light bill, didn't have transportation, was taking 3 buses to our office. These are all things that could be helped with certain things, with having social work and care management in these organizations. So now, like, people think this is only a 1 to 2% problem. I really think it's more like a 15 to 25% problem. And if you estimated that at a 15 to 25% in Nevada, that's 4,800 to 8,000 deliveries per year with a problem. And we don't have to solve all of poverty to switch this, but even if we get a 1/4 to 1.5% reduction in preterm birth, that saves $2 to $6 million per year in NICU stays alone. And that doesn't even count for things such as long-term care, educational changes in the state, from kids with neurobehavioral problems from what's happened from an extremely preterm birth. Wanted to talk a little bit about a special thing near and dear to my heart is reducing preterm birth. We talked about the differences between Nevada and US, and where we stand. Nevada right now is our D at a 10.4% rate. We're 37th in the country. And prematurity, as I was just kind of talking about, has these kind of cascading effects. Preterm birth leads to longer neonatal hospital stay, which leads to NICU admissions, which has some neonatal morbidity, which leads to long-term health concerns, which also at the most severe report gets to neurobehavioral concerns and stress upon the educational system. If you look at the outcomes or in the dollar cost of outcomes, if you take the 2026 data, unfortunately, or 2006 data, that's the last data we have on this actually. If you take that and you COLA adjust it, the estimated cost of preterm birth in the United States is around $34 billion per year. NICU per day for Medicaid in Nevada is around $1,860 in 2021. NICU for commercial was $3,000 to $5,000 per day. Preterm birth has a big effect on cost. And right now, the doctors are challenged because even the most integrated scoring systems fail to find 50 to 60% of the pregnancies that deliver preterm. We're just missing the target overall on who is going to deliver preterm. But what if we could reduce preterm births by over 50% prior to 32 weeks? What if we could lessen neonatal morbidity by 20%? What if we could reduce NICU admissions by 22%? It's all possible now. This is my paper that came out in January, the largest preterm birth study in the United States, probably in the last 3 decades, enrolled over 5,000 patients. As you could see, the institutions on there, University of Kentucky, University of Virginia, LSU, Icahn School of Medicine, Yale, UCSD, Boston University, Ochsner, really big programs around the United States. And all we did was use a maternal blood draw that predicts preterm birth. And we bundled it for the first time in a large study with low-cost interventions for those people that screened at higher risk for preterm birth. Low-dose aspirin, vaginal progesterone, and a weekly telephonic nursing call to these high-risk patients. Very low risk, very low cost. And I don't know if you know how to read these graphs, so I'll try to go through them for you. But if you look at the right-hand side where it says ratio, that's the confidence interval. And if you get the ratio, if you have a measurement of 1, that means there's no change. If you have a change that's off the line and the not only the box, but the lines are off the 1.0 line, that means it's significant, okay? So what we found was, and if you take 1 and you minus the number next to it, like point on the first line, neonatal morbidity and mortality, it says 0.8. If you take 1 and you minus 0.8, that means there was a 20% reduction in neonatal morbidity and mortality in our study. There was a 22% reduction in NICU admission. There was a reduction in preterm birth prior to 32 weeks by 53%. And there was a preterm birth reduction prior to 34 weeks by 35%. All of these things are fantastic. And but what even makes it more is you really didn't need to screen a lot of people to get these results. If you looked at it overall, right now, our society in the United States recommends that we measure everybody's cervix for preterm birth prevention. The cervix is thought as a fence that holds the pregnancy in. You have to screen 150 patients to prevent one NICU admission. All right. In our study, doing this blood test and intervention, we only had to screen 38.5 patients to prevent one NICU admission, almost 4 times more effective than what our national guidelines right now. So to reduce this burden of preterm birth, I've been able to talk to some MCOs, and Molina is currently running a pilot on this. Silver Summit is in final negotiations of running a pilot. But I would recommend that we possibly talk to the test maker and have the state negotiate a cost for the test. If you have a universal program with 400 people testing per day and you save 1 NICU day for every 4.2 patients screened, for the 13,000 Medicaid patients, that'll save $500,000 a year, and you're going to get greater long-term costs and reduction from neonatal readmits, neurobehavioral abnormalities, and special education needs that these kids are going to have. I'm pleased to say that another state, Illinois, has seen the study, and unbeknownst to me or the company, they have introduced a bill for this test coverage. And this is the state senator that put it. She's the Democratic head of the Senate, and she's put this in for vote for Illinois for their public aid code. So another state is already doing it or trying to do it, and I would like for us to think of this as a possible means moving forward.
I wanted to just jump in and give a 5-minute warning, just to make sure that you have the opportunity if there are other very specific things you want us to hear from you. And also we have all the materials, so we will make sure to take those for detail. All right.
I'm going to go on what has been stated again today. I think you guys, if you want to, I will refer you. I really think the NICU deregionalization is a major, major problem. 1 out of 20 kids dies unnecessarily in a NICU where less than 100 very low birth weight babies are. There's only 2 NICUs in the state that do more than that. And these areas are just basically high volume profit centers, or places are high profit centers to hospitals. And I think there is a problem. And I think we need to push back to a more regionalized nature of a level 3 regional and a level 3 community. What I would like you to do is you could, if you want, I've also talked about this before the legislature, and if you want to hear all of that, I think we should, maybe I could post that online and you could go to the end of the talk and basically hear how I went through this step by step. I also will tell you that an article in Nevada Current came out, and it was also in Apple News is the biggest thing of the day. And so many people have read this, and I've received multiple phone calls of support from pediatric surgeons in our state, pediatric cardiologists, payers, other OBGYNs, and even our competing MFM groups saying, my God, this is so needed. We really need to get rid of this deregionalization and regionalize like all the major societies want us to. So I'll end on that with that. What I did want to talk about is our OBGYN physician shortage. We rank 46th in the country with OBGYNs per population and have a effect on our rural areas. There's been a lot of talk about doulas. The data for doulas is very poor, guys. There is some general data showing decreases in cesarean delivery and also in Black populations, which is really important. But if you look at, there's 2 recent meta-analysis, it even says the quality of contributing studies was generally low with wide confidence intervals for outcomes such as cesarean delivery. If you look at Cochrane, which is the king of the meta-analysis databases, they basically say subgroup analysis should be interpreted with caution and considered as exploratory and hypothesis generating, but evidence suggests continuous support with certain provider characteristics and setting where epidural analgesia was not routinely available. That's not Nevada. In settings where women were not permitted to have companions of their choosing in labor, not Nevada. And in middle income country settings, not Nevada. So I really think we should be careful about that. And the reason is if you look at it, doulas don't really have the same requirements that OBGYNs do, but the doula payment is $900 for a delivery and up to $1,500 max. The physician or the midwife, the payment for the vaginal delivery alone is less at $882 for CPT code 59409. So we're paying doulas with less requirements, less other things, more than we are for a vaginal delivery to an OBGYN. And that's why we have problems with access. I do want to talk really quick, 2 minutes, value-based care. My background on it, this is the quality measure paper I wrote for the whole United States on this. I also reviewed the ACOG changes in payment guidelines. I would be very cautious about changing value-based payment guidelines before the 2027 CPT codes go into place because you don't even know how that's going to change. And I think the biggest problem with that is they change those codes mainly because of issues with changing workforce in the United States and moderate, low, and high-risk care, and how bundles didn't approve that overall or didn't go look towards it. I think the roadmap that we saw is really aspirational and important, and it recognizes the fragmented care that we have, and they do concentrate on metrics, which are good, but I think concentrating on outcome metrics is difficult because pregnancy is a very long dynamic episode. It's not like a knee surgery, you go in and you're done. It's 9 months, then plus up to a year postpartum, and people really evolve in their care. People can get gestational diabetes, 13% of the population. People can get preeclampsia, another major part of the population. Preterm labor, as I discussed, about 50, 60% of the cases can't be predicted. So the problem is most value-based models don't account for this evolving risk. And it's forgotten that it's a treatment of 2 patients, and we're looking a lot at like things such as cesarean section, but we do have to look at more things like preterm birth and NICU admissions. And so the value-based models must also look at that. And for my last slide, all I want to do is talk about this. I'm really nervous about outcomes that are not risk adjusted, okay, especially over a year-long period. Providers, that would make providers not want to care for people of higher risk populations because the rewards or punishments given are not going to talk about how high their risk is. Like, for example, if you have somebody with obesity, they're much higher risk of getting gestational diabetes and then cesarean. African American populations have higher risk of preeclampsia. We don't want to have people choose populations of patients that are lower risk. We want them to basically give the highest quality care to every single patient. And hence, most people are now going towards process models rather than outcome models because of that. And with that, I'll end. Sorry I had to go fast, but we'll go from there.
I just want to say thank you for covering so much ground so quickly and also providing some really actionable examples and things that I think we definitely can take into consideration as we move forward. So thank you again for being here today and all you did to prepare and bring those materials. And again, for all the commissioners, all the remaining details in the materials that you guys received, so we can certainly look through that. Okay, I am going to hand it back over to Dylan because I think that brings us to public comment.
Yeah, and if anybody has any questions for Dr. Uriye, just let me know and I can make sure that we can get those answered. That moves us on to public comment. This item on the agenda offers an opportunity for public comment. No action may be taken upon a matter raised under the public comment period unless the matter itself has been specifically included on an agenda as an action item. To provide public comment telephonically, you may join the meeting by dialing 775-321-6111, and when prompted to provide the meeting ID, enter 981-401-478#. Please press star 5 to raise your hand during the public comment periods to provide your comments. Comments will be limited to 3 minutes per person. Person making a comment will be asked to begin by stating their name for the record and spelling their last name. If you wish to join, please press star 5 to raise your hand on the phone, and if joining by computer, use the raise hand icon at the top of the screen. Chair, I see no one wishing to make public comment at this time.
Thank you for that. I don't know if it's easy to bring up that QR code again for the
Yes.
survey, but I do want to put in one last plug for participation. And even if you want to send out that link to others or share that, we continue to look for great input from a broad audience around all the things that we're considering, and we'll take into account as we think about some of the BDRs that we'll be moving forward with. So just want to put one last plug in for that. We'll loop back again to just say thank you so much to all the presenters today. Just a wealth of information and great dialogue. And I think with that, we are just about at time and we will adjourn the meeting. So thank you so much for everybody joining today. Appreciate it.
Thank you all.
Thank you.
Thank you.